NEET PG 2021 happened finally, okay, after a long waiting period. It was in September 2021 that we had this NEET PG exam, and right now we are with this recall session. Now, in between NEET 2020 and 2021, approximately 19 to 20 months. So, long waiting period. These students who've been preparing for the 2021 exam have gone through tremendous ups and lows and highs and lows and downs. But finally, when the exam came a reality, it was an exam which probably had a fair share of easy questions, a few tricky questions here and there, and primarily testing a lot of hospital-based knowledge. And I think a student who is pretty level-headed, who has studied with a decent base, should be able to make it, although results are not out as yet. So let us see how it has gone. So who should be watching this recall session first? So we have had a lot of hue and cry once the exam is done as to when the recall is, etc. When I was happily sleeping. So I guess a lot of recall sessions you can actually see on YouTube. So many of the teachers have done in different platforms. And why is there a need for us to do it right now? Let me just make it very clear. This is basically for a few set of students. The first set are probably who like me. So they should be definitely watching, because whoever likes me, whatever I do, they should watch. That is the purpose of saying that you like a person. Coming to a serious note, this is primarily designed for students who are preparing for the 2022 NEET exam, who have maybe not given the exam in 2021, 2022 is their first attempt, and more numbers who have given the exam in 2021 without any serious preparation. They would be doing their internship, and they are prima facie focusing on the 2022 NEET exam. So it is basically designed for them. What is expected out of this discussion? This is just for them to get an idea of what were the weightage areas in 2021 exam. We had weightage areas in 2020 exam, and when we compare that with the weightage areas in 2021 exam, we could at least strike some concordance. So weightage areas are more or less the same. None of the questions have been repeated, so there is no point in going behind repeat questions. There is no point in digging deep into the questions, because I have not given this exam myself. This is a recall kind of a question that we have. So this question may be right. This question may have its own degree of mistakes, its own fair share of wrong things inside. So that's pretty much acceptable. So it's not the final answer that is so important over here. What is important is for you to understand the exam zone, so that at the end of watching the revision sessions as well as these recall sessions, which are very new in the app, you get an idea as to, okay, these were the core zones that they did focus. It does not necessarily mean that the same zones are going to come, but you have to definitely be doing these zones. There is no way you can go to the exam without doing these zones. So rather than repeating the same question over and over again, studying these repeat questions, if you identify the repeat topics or the so-called zones, they are going to hold you in good stead for the exam. When we just scan through the paper, primarily, if you see through the paper, this was the distribution. You can see different chapters. This is a different kind of a distribution, because almost every time over the years, the distribution has not been exactly like this. You can see that endocrinology has been overtaken by cardio, hemat, etc. And you can also see that nephrology is very less, only 2 questions. But if you do add acid-base to nephrology, then it comes to a bigger number. I have included acid-base and electrolytes as a separate chapter, because that has been highlighted so much in this year's exam. And so-called clinical pharmacology, which is pharmacology with a clinical side. That's another thing that I have tried to add. For people who have given their exam, there is no reason to actually watch this particular thing. This is again just to highlight on a few important zones which you shouldn't miss going for the next year's exam. And for people who have done the exam like me, who are very fidgety, restless kind of guys, who want to know what is the answer for this, let me tell you, if you had a published paper after the exam, then probably with confidence I could have said that this is the answer. These are most probable answers out of the most probable questions that we have got. So please don't hit me saying that this is not the way it was discussed there, etc. No, nothing. This is something which I feel is the question and I feel is the answer. So maybe right, maybe wrong also. So we are more interested in knowing the crux behind the question, from where the question is, and how we can probably tackle a question from a similar zone in the upcoming exam. So this time around I have not gone chapter wise. I have gone for a more random discussion. Last time we did a chapter wise discussion. So this time we're going for a more random discussion. Let's start off with the first of the questions. The first of the question is a very simple question. You can approach this question in 2 ways. This is very similar to the question that I have taught. So the third reason for me doing the video that I forgot to tell you is for me to actually reassess. This is very important to me to actually stop and look back as to whether I have taught the key zones. These are the key zones. Have you discussed this in enough volume and enough depth for the exam? So when a question comes, the first thing that cuts across my mind is whether I have taught this for the exam. If I have not taught, then I feel bad. So I just have to be going back and looking at it. But it shouldn't be a feeling that I'm coming and saying that yes, this is from my notes, that is from my notes. So that is not the thing. It's just for me to see whether I have taught this properly. Okay, so please take it in that way only. This is a question more or less very similar to what we have discussed. There are two ways of looking at it. One is a clinical way, and then is the ABG. Or to just look at it clinically, just look at it ABG wise and then combine. That's also possible. Let us look into this question just from the ABG angle. That's what I taught you. Without looking into the clinical thing, diabetic movement, whatever, not bothered. Just to look into the ABG angle. Looking into the ABG angle, we need pH, we need HCO3, we need PCO2. These are the three most important things that we require. We fix the absolute value 7.4, 24, 40. So for ABG reading without a clinical perspective, we have fixed values 7.4, 24 and 40 are our fixed values. So 24 is milliequivalents per liter, 40 is millimeters of mercury. So this is basically what we are looking into. In this question, if you see pH is 7.52, pH is 7.52 means you write it as alkalosis upfront itself. So you know that it is alkalosis upfront itself. When you look at the HCO3, HCO3 is 26. So 26 means it's increased. Okay. PCO2 is 20. So PCO2 20 means PCO2 has actually fallen down. Okay, so from this much of data that you have, without even looking into the question paper, you know that HCO3 has moved along the lines of alkalosis. PCO2 has actually fallen down, which is also along the lines of alkalosis. So basically, it's a metabolic alkalosis you can see over here. PCO2 has also fallen down, which is also a kind of alkalosis. So you can cement on the fact that it is an alkalosis. It is a metabolic cum respiratory alkalosis. Okay, so metabolic plus respiratory alkalosis is basically this ABG. It's very, very simple. So there is a metabolic alkalosis, there is a respiratory alkalosis, provided these values are correct. God only knows. Okay, so from this, it is definitely that way. Metabolic plus respiratory alkalosis. So they have not asked for any kind of option like that. They have asked for a few other things. Renal tubular acidosis and decay you can strike off because they are acidotic conditions. Septic shock, obviously when you have shock, you have hypoxia, you get lactic acidosis, so that's also out. Without reading the question, I will mark the answer as vomiting. Okay, this way you can answer this question because everything else is acidosis. This was almost the same question that they asked. So that way is a very, very simple way of answering the question without reading the question per se. So when you get an ABG, I have taught you this in detail that ABG is useful in a lot of ways. Even when you become a PG, the way to attract your house surgeons, the way to attract your final years is to by basically being very strong with ABG and ECG. ECG many people may be knowing, ABG not many of them know. So obviously you can excite a lot of your juniors and become a star. So ABG does help in that also. So that's one way of looking at it. So persistent vomiting you can straight away mark as the answer. Now if you read the question, persistent vomiting gives a history of consuming food from outside. So vomiting, losing acid is probably one way, losing chloride. So you are having metabolic alkalosis. Very, very simple way of looking at it. Vomiting induced alkalosis. Correct. So that way also you can answer this question. There is no reason to look into sodium, potassium chloride and crap over here because of the simple reason that you are not dealing with decay renal tubular acidosis. Chloride for a clinical person, if I see the 67 chloride, then we are going one step ahead. That's not required in this question, but you can again see the discussion. There are two or maybe say three ways you can actually get alkalosis. One is that you consume a lot of alkali. That's why I've written this third, and that's very, very rare. Probably after correcting acidosis, something like that. It's okay, it's not common to generate large amount of alkali, you inject alkali into the body, not common. The other two mechanisms are actually speaking very significant. One very, very important mechanism of developing alkalosis is chloride depletion. This is considered to be one major mechanism of developing alkalosis. Any big textbook you took into, the two main mechanisms of developing alkalosis are one, chloride depletion. Second is mineralocorticoid and apparent mineralocorticoid excess, which is associated with potassium depletion. So chloride depletion is one way, another one is potassium depletion, which is basically a part of mineralocorticoid excess. So wherever you lose chloride, you will develop alkalosis. Wherever you have mineralocorticoid excess, you will develop alkalosis. So that is basically the whole point. And alkalosis goes through three phases. One is a generation phase, second is a maintenance phase, and third is a correction phase. So these three are the three phases of alkalosis. Generation is, that's what I'm saying, either you lose acid or you generate alkali. Either way it can happen. Maintenance means once you have acidosis, okay, the prime response of the body is to actually diminish the net proximal fluid reabsorption. In alkalosis, it is the opposite. It is to increase the net proximal fluid reabsorption. When there is an increase in the net proximal fluid reabsorption, bicarbonate with alkali with chloride gets reabsorbed. That is how this alkalosis is maintained. Once the proximal fluid's capacity is overwhelmed, then the distal tubule, the collecting duct, will actually try to do this, where collecting duct will actually reabsorb all the chloride, but it cannot reabsorb bicarb. Bicarb reabsorption happens only at the level of the proximal tubule. So bicarb will be lost in urine. So that will correct the alkalosis. That is the whole process. But the ultimate point is acidosis will diminish proximal fluid reabsorption. Alkalosis will enhance proximal fluid reabsorption. That is how with fluid reabsorption as well as with a lot of chloride and alkali, this is being maintained. So generation, maintenance and correction are the three phases. But if you look into the disease on the whole, classification is based on this chloride depletion and mineralocorticoid excess, which means that wherever you lose chloride, you are essentially going to develop a chloride depletion alkalosis. I'll just show you this. Chloride loss, vomiting, post-diuretic phase, post-hypercapnic phase. Because what is hypercapnia? Respiratory acidosis. What is the compensation for that? Metabolic alkalosis, villus adenomas, congenital chlorhydria. So anywhere you are actually losing chloride, we are basically talking about enteral or parenteral. Wherever you are actually losing chloride, you're talking of chloride depletion. And then when you are having a mineralocorticoid excess can be something like a Conn syndrome, which is a true mineralocorticoid tumor, or it can be apparent mineralocorticoid excess, glucocorticoid remediable aldosteronism, or Liddle syndrome. All these things can be actually there. Okay, so that is how we actually look at the whole thing. So in very simple terms, if you are asking me what could I be thinking of when I think of an alkalosis, I would be thinking of one, chloride loss. Okay, under chloride loss, I would be thinking of GI loss of chloride, which is mostly vomiting and nasogastric suction, which forms the most important cause still. Then drugs which I use, predominantly my diuretics, which are going to wash out chloride. Then chloride losing diarrhea. And two things I will specifically remember. One is recovery from hypercapnia, which I have mentioned, and cystic fibrosis. These are two things I would like to remember. Mineralocorticoid excess, a lot of things have been written, but I would like to remember Conn's, Liddle, Cushing is also there, AME is there, GRA is there. This we will again discuss. Okay, there is something common about them. These five. So that's also very, very clear. And a combined mechanism, that means combined mechanism of chloride depletion as well as mineralocorticoid excess is potassium depletion, is what we actually see in Bartter and Gitelman. So that's where we are actually looking into, that is Bartter and Gitelman. Okay, so on the whole, if I write, chloride depletion is one mechanism, mineralocorticoid excess and potassium depletion is another mechanism, and third mechanism is a combination. And under combination, you have to remember Bartter, Gitelman. Okay, under chloride depletion, you have to remember all the cause of volume loss. And whenever there is volume loss, RAS activation, once again, you know. Mineralocorticoid excess also, you know. This is how we go with this. Okay, how can the examiner ask you a question with respect to this? An examiner can actually ask you a question where a patient presents with frank hypokalemia. When a patient presents with frank hypokalemia, you find out that it is urinary potassium loss and there is metabolic alkalosis. This is one way you can get a question. Second way you can get a question is when there is a frank volume loss, or what I call as a Ecf volume depletion. Now this is the question that we have seen in this question paper now, where you have a frank volume loss, Ecf volume depletion. This Ecf volume depletion is what we call hypochloremic metabolic alkalosis. Why? Because you are losing volume, you are losing fluid, you are losing chloride. That's a chloride depletion. That's supposed to be the most important thing. So, hypochloremic metabolic alkalosis. It's exactly the same question that we saw for the exam. Okay, it's a case of hypochloremic metabolic alkalosis. Chloride levels 95 to 105 is normal. Here it is very, very low. So, it's a hypochloremic metabolic alkalosis. It will respond to fluid therapy, or you have to basically replace fluids in this patient. Fluid repletion is the mainstay of treatment. That means if you replace fluid, then the patient will become alright. So that's the case of hypochloremic metabolic alkalosis. Correct. Here on the other hand, you are having a definite other set of causes where it is not fluid responsive. Okay, not fluid responsive. Okay, so that's why this can be actually called as fluid responsive or chloride responsive or saline responsive. This can be considered as not fluid responsive or non-chloride responsive or non-saline responsive. That is another way of looking at it. Okay, that's why some people call this as chloride responsive alkalosis and this is chloride resistant alkalosis. Some people call it as saline responsive alkalosis and saline resistant alkalosis. Where you shouldn't go wrong is mechanisms and terminologies are different. When I say mechanism, I mean chloride depletion one mechanism, mineralocorticoid excess and potassium depletion one mechanism, and combination is another mechanism. When I'm talking about the classification, it is chloride responsive alkalosis and chloride resistant alkalosis. Okay, so those two things be very clear. And third thing I want you to remember is What is the value of this test called urine chloride? If urine chloride is more than 20, okay, and if urine chloride is less than 20, urine chloride is less than 20 means you are losing a lot of chloride. We can lose chloride from the GIT mostly. We can use chloride through diuretics. We can use chloride through post hypercapnia, villus adenoma, etc. Diuretics I'm not mentioning because it depends upon when you have started early or late phase. But generally, chloride responsive alkalosis, all of them have loss in chloride. So that's why their urinary chloride will be less than 20. And this chloride resistant alkalosis, if you look into, chloride resistant alkalosis generally have a urine chloride more than 20. So that is another question that has come for the exam. So I told you mechanisms, 3 mechanisms, classification 2 of them, value of urine chloride, if less than 20 think of chloride responsive or saline responsive, if more than 20 think of chloride resistant or saline resistant. Simple. Now, this is again a repetition of what we have studied, but just to put things into perspective. Now, if you get a question this way, that means hypokalemia is the main presenting feature with the weakness and all those things. Urine potassium is high, that's what is urine potassium loss, and there is metabolic alkalosis that can be called as chloride resistant or non-fluid responsive or saline resistant. Inside that we have normal to low BP. There is one heading, and then you have another heading called high BP. Please go and watch this. Normal to low BP, we have 2 examples. One example is called as Bartter syndrome. Second example is called Gitelman syndrome. And high BP, the examples are Cons, Liddle, Cushing, AME and GRA. Con, Liddle, Cushing, AME, GRA. AME means apparent mineralocorticoid excess, GRA means glucocorticoid remediable aldosterone. Correct? So this will be the complete picture. Hope I think it's very, very clear. Now if somebody is asking you how to actually put it into perspective, you must say that I would think of one chloride responsive alkalosis which is characterized by low urine chloride, which is due to a volume depletion, which is mostly associated with GI loss, vomiting or maybe nasogastric suction, etc., which also has an important cause in cystic fibrosis, which also has a cause in post hypercapnic state, okay, and diuretics. This I would always love to compare with a chloride resistant alkalosis, okay, which is characterized by potassium depletion. Correct? In this alkalosis we have normal to low BP and we have high BP. Normal to low BP we have Bartter, normal to low BP we have Gitelman, high BP we have Cons, we have Liddle, we have Cushing, we have AME and we have GRA. This is how you complete the whole picture. Okay, there shouldn't be any doubt on this. Just try and go back and see the videos on Bartter, Gitelman, etc. for comparison. If you have this hypokalemia, metabolic alkalosis with Bartter, Gitelman kind of a setup, you'll be having normal to low BP, where Bartter is always characterized by increased calcium, hypercalciuria, and it is also characterized by increased magnesium in urine. So, increased calcium and increased magnesium in urine. What's called hypercalciuria, hypermagnesiuria, and because of hypercalciuria, stones. Gitelman, on the other hand, will be having hypocalciuria and will be having hypomagnesemia. Bartter will be hypermagnesiuria, but in 80% magnesium levels in blood are going to be normal. Here, hypomagnesemia. So, very, very important. Hypocalciuria and hypomagnesemia are seen in Gitelman. Hypercalciuria and hypermagnesiuria are seen in Bartter's. And then you have this Cons, Liddle's, Cushing's, AME and GRA. Those are the other things with high BP. This is normal to low BP, this is high BP. And I'll just quickly tell you what is that. Cons stands for primary hyperaldosteronism, which means it is mostly aldosterone secreting tumor, which is either hyperplasia or adenoma. Which is more common? Hyperplasia is more common. So, primary hyperaldosteronism because of hyperplasia greater than adenoma. To be very strict, Cons is adenoma, but primary hyperaldosteronism is okay. That means you are having a case of aldosterone high, renin low. Liddle is pseudo hyperaldosteronism, which means that it is due to ENaC, gain of function mutation. Epithelial sodium channel gain of function mutation. That is also characterized by what? Hypokalemia, alkalosis, high BP. Then you have something called Cushing, okay, which is also characterized by hypokalemia, alkalosis, high BP, where you are having cortisol in excess, and cortisol has mineralocorticoid action. So, same thing. Then comes apparent mineralocorticoid excess, where you are having something called cortisol not being converted into cortisone because of a genetic reason. That is due to deficiency of an enzyme called 11-beta hydroxysteroid dehydrogenase. Because of this deficiency that is there genetically, which is autosomal recessive, it's not happening and you are having a cortisol excess. And lastly, glucocorticoid remediable aldosteronism, which is also a genetic thing where ACTH now takes control of aldosterone. Normally RAS is in control of aldosterone, ACTH is in control of cortisol. Here ACTH actually takes control over aldosterone. So that's why if you give glucocorticoid, it is remediable. So these are the other things which you can always watch. So this is being discussed under different spaces. Metabolic alkalosis approach is discussed under ABG. Hypokalemia approach is being discussed under endocrine. You can go and watch this to get a complete picture. But it's a very simple question. You can rule it out in 10,000 ways. I have shown you so many ways to actually differentiate this and a basic idea on metabolic alkalosis. Okay, so these kind of questions, please don't get it wrong. Not because of anything else, but I feel very worried. Not for you, but for me, because if this is a question which a student who's watched my videos goes wrong with this, then I feel that I have not given the necessary emphasis, and that emphasis part is why I am doing this. So you have to be. Which of the following is incorrect regarding pheochromocytoma? This again is something which I don't think anybody should ever in their life get wrong, because if you look at the 10 most favorite topics of mine inside the whole medicine that I have done, or overall if you ask me 10 favorite topics of mine in medicine, definitely pheo will be there. And if you watch the videos on pheo also, you will understand, because pheo is a topic where I feel time is less for me to explain, because I can just keep on talking about pheo. So here let's look into the question. What is the first statement? Can present as hypertension alone and sometimes with vomiting and pain abdomen. This is a statement. Now you can actually see the slide. This is what we have discussed. The characteristic triad. So before that, panic attack you see in 75% patients, and I always have told you that the most common presentation of pheo is with a panic attack. But remember that less than 1% of panic attacks have eventually turned out to be pheo, which means if you look at the causes of panic attack, then pheo is way down the list. But does pheo present as a panic attack? Means yes. And this is the so-called triad: episodic hypertension with sweating and tachycardia. This is what we actually call the triad of pheo. Episodic hypertension plus sweating and tachycardia. Every time patient comes with an attack is typically characterized by hypertension, typically characterized by sweating, and also characterized by tachycardia. This is what we say. And I have always told you this phenomenon called 6PW. 6PW means there are 6 P's: pain, pallor, panic attack, palpitation, perspiration, and postural hypotension. So these are the 6 P's of pheo. If you look at that, again I have told you that episodic hypertension presenting as the classical feature is very common to see, but patients with pheo can have sustained hypertension. In fact, sustained hypertension is one thing. When you have sustained hypertension, you should be thinking of pheo. Sustained hypertension, episodic hypertension, postural hypotension, all these things are possible. Yes, pain what we refer to here is the abdominal pain, and I told you that's very closely linked to hypercalcemia. Hypercalcemia, abdominal pain, pheo, again we have had a lot of discussions on that. Pallor I told you is a very important finding, because generally pheo has secondary erythrocytosis. So it's important to note this, because generally it is secondary erythrocytosis and the patient has polycythemia. So whenever you are having pallor, again think about malignancy. I told you to throw the rule of 10 into the wastebasket, because it doesn't hold true now. There is no 10% bilateral, almost 25% are bilateral, almost 25% are extra-adrenal, and 40 to 50% are malignant. Panic attack is what we are discussing: palpitation, tachycardia, perspiration, sweating, and postural hypotension. So if you look into this option, can present as hypertension alone? Yes, very much present as hypertension alone. You can actually see this. One presentation is this triad. Then just with the episodic hypertension or just with the sustained hypertension is possible. Incidental detection again possible. Sympathetic drive induced weight loss, volume depletion, that way also it is possible. W stands for weight loss. Okay, this is very clear, and I have shown you this slide also. Hypercalcemia correct, hyperglycemia correct, weight loss correct. I told you hypokalemia is not seen. Sympathetic paragangliomas, functional paragangliomas actually have more malignant potential. 75% have postural hypotension at one point in time or the other. Between sustained and paroxysmal, now recent data say that more people are having sustained. But at the time of presentation, episodic obviously there, but more people are having sustained. Familial syndromes, I told you, MEN2, VHL, we've discussed all that. Neurofibromatosis, all these syndromes are bilateral, except NF1. NF1 is one thing where you are having unilateral. So the others are all bilateral. So this way also we have actually discussed. Okay, so can present as hypertension alone and sometimes with vomiting and pain abdomen. That's right. So let's look at the second statement. Diagnosed by urine, VMA and catecholamines. I have told you this, VMA etc. currently has no much role, but urine catecholamines definitely the way we diagnose. I have told you this test which has got a sensitivity which is 98% and specificity which is got 98%, and hence the first test to be always done is 24-hour urine fractionated metanephrine. 24-hour urine fractionated metanephrine. And if that is actually positive, then we go to the investigation of choice, which is an MRI. And then if you're not able to pick up anything on the MRI, then we go for gallium DOTA scan and all those things. 24-hour urine fractionated metanephrine has got 98% sensitivity, so still you can miss 2 patients. If you think that you are missing those 2 patients, then a test which has got 100% sensitivity is the plasma fractionated metanephrine. So what we generally do is we start with the urine fractionated metanephrine. If that is positive, then we go for MRI, and if MRI is able to pick up adrenal mass, there ends the story. Urine fraction metanephrine positive, MRI not able to pick up anything, then we think it is extra-adrenal. For extra-adrenal, previously we did MIBG, then we did PET, now we think gallium DOTA is the best one. So that is our investigation that we do if we not able to find anything on the MRI. If you have symptoms, family history or everything very suggestive, but urine fractionated metanephrine is not showing anything, means then we have to probably go for plasma fractionated metanephrine. So all that we have discussed, I think, umpteen number of times. So start with the urine fractionated metanephrine, go to MRI, make a diagnosis. Starting with urine fractionated metanephrine, going to MRI, not seeing anything, take gallium DOTA scan to look for extra-adrenal mass. Starting with the urine fractionated metanephrine, but still not showing positive, but you are highly in doubt, going for an investigation that has 100% sensitivity, that is plasma fractionated metanephrine. Okay, so that's also correct. Surgical excision is the definitive treatment. I told you, whatever happens, the treatment is to remove, and that is laparoscopic retroperitoneal adrenalectomy. That is what we generally do. And surgical excision is the definitive treatment, but you have to prepare a patient for surgery. And this is a slide on that, where we have actually discussed this. You start the patient on alpha blockers first. Then that's almost like 7 to 10 days prior to surgery. 2 to 3 days prior to the surgery, you start the patient on beta blockers, and there is no particular beta blocker of choice per se. We can use atenolol, we can use metoprolol. Alpha blocker, almost always phenoxybenzamine is our choice drug. And then to control blood pressure, you can also try nicardipine, mitarosin if it's not working. And then intraop hypertension, you can try sodium nitroprusside, nicardipine, phentolamine, etc. for intraop control of BP. And clonidine suppression test was an old test that was done in the past. Okay, so essentially starting alpha blockade 7 to 10 days before. The question statement is that you can use propranolol initially to manage hypertension. That is rubbish. Because if you block the beta without adequately blocking alpha, then there can be serious organ hypoperfusion. Because this organ perfusion is basically maintained like this way. So when you are giving an alpha blocker, automatically the vasoconstriction that is there by or that is produced by alpha is being blocked. Now if you are actually blocking a beta before that, then already alpha is actually producing vasoconstriction. That perfusion is being maintained with the help of beta. So if you block that, then we serious organ hypoperfusion. You can't allow that to happen. Beta is started, like you're planning for surgery on Monday. Previous Friday you start alpha. This Friday you start beta, and Monday you take for surgery. So this is something which we have discussed so many times. So propranolol is never given initially. It is alpha blockade followed by beta blockade. So there is nothing much in this. I just tried to discuss in and around the question, just to once again bring to note the next exam zone, and that is adrenal medulla. Adrenal medulla is so very important exam zone. The first zone I told you was ABG. Everything about ABG is important, but here it is a specific point that I am trying to tell you. Adrenal medulla, which includes pheochromocytoma, MEN syndrome, Meon syndromes, PGA. There are only 4 questions inside this, or 4 topics inside this, but you have to be very thorough with pheochromocytoma, MEN syndrome, Meon syndromes, and PGA. And it's definite to actually get a question on this. Okay, we go to question number 3. Question number 3 is like too simple a question, so there is nothing for me to discuss on this. I just want you to be very clear once again with the approach to a weakness kind of a question. On an approach to a weakness kind of a question, what I have actually told you to be very simple with respect to this. Lesion in an element kind of a weakness. UMN kind of a weakness will have weakness, spasticity, hyperreflexia, plantar upgoing, and all those things, which is obviously there. In any kind of another kind of a question, you need to be looking at whether it is anterior horn cell, whether we are dealing with the ganglion, whether we are dealing with the root, which is also called our spinal nerve root. Are we dealing with the plexus? Are we dealing with the nerve? Are we dealing with the neuromuscular junction? Or are we dealing with the muscle? So this is basically what it is. Anterior horn cell is a pure motor thing. So that's the first point. It is asymmetrical. It's mostly got degenerative etiology. So very long-standing degenerative etiologies. It will be associated with fasciculations. Okay, very important, and will be having loss of bulk, or what we actually call as atrophy. Asymmetrical atrophy fasciculations. If you look through, and wasting. If you look through this particular question, there is no kind of a muscle weakness that is being given over here. There is no asymmetry, there is no atrophy, there is no fasciculation. So obviously we are not talking about anterior horn cell. If you look at the ganglion, ganglion is a pure sensory thing where you are going to talk about sensory ataxia more than anything else, especially Jogren and paraneoplastic. There is nothing sensory over here, so you strike it off. Root will be having extreme pain along the distribution of the root, so there is nothing called pain being mentioned here, so you strike it off. Plexus will be again having asymmetrical with combination of roots, so again combination of roots, again pain, so again strike it off. Nerve will be having a sensory more than motor involvement with a distal to proximal evolution with this glove and stocking and all that, so strike it off. Neuromuscular junction, so muscle again will be having so much of muscle weakness here, again not mentioned. Neuromuscular junction, I have told you in my approach to LM, is so typically characterized by fatigability. That is repeated activity, the patient coming out with fatigue, so excessive fatigability. So this brings us to Duchenne is a muscle disease, so we are ruling it out. SLE is an autoimmune problem that's got nothing to do with any of these things, again out. So which means that we are having only two DDs now. One is myasthenia, second is myasthenic syndrome. And myasthenic syndrome is Lambert-Eaton myasthenic syndrome, which is always going to be a paraneoplastic thing. Young patient at this point in time, you're not going to talk about it. And to have myasthenic syndrome, you should be having ANS symptoms. Okay, here it is mostly ptosis and dysarthria, difficulty in speech and difficulty in swallowing also, so which is very much a progressive myasthenia, and I have told you how it has actually evolved from these extraocular muscles to the bulbar muscles to the proximal muscles, how it actually goes. This is my slide to show you fluctuating muscle weakness with muscle fatigue, most versus activity. Okay, this is exactly what we have discussed: ptosis, diplopia, dysarthria, dysphagia, fatigue on chewing, and less than 5% proximal muscle weakness. Okay, if you have studied this, it's a cakewalk question, but the point is not to answer this question, but the point is to understand that approach to weakness is important, approach to element weakness is important, how to localize it to neuromuscular junction is very important, comparing between myasthenia and myasthenic syndrome is very important, and these are the points in favor of myasthenic syndrome. Very mild diplopia and ptosis, this statement is mandatory. Incremental response, there it was decremental, here incremental. Proximal lower limb weakness will be more predominant. Autonomic nervous system findings are a must. Paraneoplastic, and it is presynaptic V by Q. Okay, and this is treated by 3,4-diaminopyridine. Okay, last time also we had a question on myasthenia. Every time we get some question on the other on myasthenia. Myasthenia is a very, very important topic, and I think I have done myasthenia reasonably well. You have to go back and watch myasthenia, but at the same time when you go do myasthenia, please have in mind the other points. That is why it's not this, why it's not that, because the Indian system of exam expects us to know as to why this is not the cow. More than saying that this is a cow or saying that this is a lion, you need to be knowing as to why it's not a cow, why it's not a giraffe, why it's not a tiger, why it's not a fox. That's what is expected. So exactly the same thing we are looking for here also. Let us go to question number 4. Evaluation of a patient revealed the presence of a mid-diastolic murmur. So mid-diastolic murmur plus JVP showed a prominent A wave. Okay, prominent A wave. What is the most likely diagnosis? This is a question I am not sure whether it has come in this format itself. If it has come in this format and they are looking out for options from this means, then it is some idiot who has said the paper, because JVP shows prominent A wave means that the right atrium is contracting against some form of resistance. When the right atrium is contracting against some form of resistance, either there should be a right inflow obstruction. Okay, right inflow obstruction, that is typically what we call as a tricuspid stenosis or a tricuspid myxoma or something, which can very much produce this. Or there should be a pulmonary artery hypertension. So pulmonary artery hypertension can also produce a prominent A wave. Tricuspid stenosis can also produce a prominent A wave. So both are equally possible. Prominent A wave, they have not said very, very prominent or anything. When you say prominent A wave, both are possible. Now mid-diastolic murmur means, again, TS can produce a mid-diastolic murmur. MS, which can produce PAH, can also produce a mid-diastolic murmur. What do you mark for this? Do you mark MS? Do you mark TS? If you look at the percentage-wise association, MDM, prominent A wave, no other features of pulmonary hypertension mentioned, I should be logically marking what TS. So if you think that way, you can mark the answer as TS. If I were writing this exam, I would have thought that is my way of thinking, it need not be correct, that nowhere in India, nowhere in the world, there is a case called organic TS. Organic TS is so rare. I can actually question anyone, has anyone who is discussing this paper or anyone who is actually working in cardiology seen a pure organic TS? You wouldn't have seen, because there is no entity like that. There are TS with MS combination, we have seen TS with MR sometimes, but pure organic TS as an entity does not exist. Okay, but pure organic MS does exist. So if you look for a condition which is existing here in this world right now with this kind of features, you may have to mark MS. But percentage association, if you take this and say that TS is also a common condition, then you may have to probably mark TS. If I were sitting for the exam and this kind of a question had come, first I would have thought at the back of my mind, what is this idiot asking? But then because I am also a student having to answer this question, I would have marked the answer as MS because I feel that TS is not existent. Pure organic TS is not existent. Because pure organic TS is not existent, I don't want to mark that as the answer. But if you mark TS and tell me that if you look at this question just like that and say which has got more association with the question, then I would say it is definitely TS. But I am telling you, I wouldn't have marked it, that's all. If you have marked it also, it's fine because sometimes the answer may be TS also. But my gut feeling is something that doesn't exist, how can it be the answer? So I would have marked MS. But only nothing more to say on this. Okay, so either way it's possible, but I don't know what the examiner is looking for. So examiner can either think like me, he may be testing out whether you know the fact that TS is non-existent, or he may be thinking as to the other features of MS are not mentioned, so the student should be marking TS. So that is up to him. Okay, so that's about this question. And please study everything about MS. This is the next exam zone that we are discussing. First exam zone I told you is ABG, second exam zone adrenal medulla, third exam zone lower limb weakness, looking at each of the points with special emphasis on NMJ. Fourth exam zone that we are discussing is clinical cardiology. Inside clinical cardiology, MS, MR, ASAR, evergreen topics, nothing to actually think about, just to go and study. Okay, question number 5. Question number 5 is, again, if you don't read the question at all, and just to see this nucleolar pattern, there ends the story. That's why I'm saying if you've studied ANA patterns properly, if you know one thing here and there with itself, you can answer most of the questions. Nucleolar pattern, the moment you see, you know the answer is systemic sclerosis. You don't have to read anything. Okay, I have told you this, I think, umpteen number of times. Again, people, when you watch my videos over and over again, you know that this is again one of those 10 most favorite topics of mine. So, this is to just tell you that any ANA which is done by ELISA has no value. We are looking for indirect immunofluorescence. It is the Hep2 cell line that we are looking for. 1 in 80 is the titers that we are looking for. So if it is more than positive by more than 1 in 80 Hep2 indirect immunofluorescence, then we look into the patterns. Dense fine speckled pattern is the most characteristic pattern of any connective tissue disease, which means the moment you are having dense fine speckled pattern, then you are looking at a connective tissue disease, but it doesn't specify which connective tissue disease. If you have this homogeneous pattern, then you can think of drug-induced SLE. You can think of SLE also. If you have a rim pattern, again you can think of SLE. Nucleolar pattern is suggestive of systemic sclerosis. Okay, so homogeneous pattern, rim pattern, nucleolar pattern. Finally, the whole point is most characteristic of a connective tissue disease DFS, but you don't know which type. Specific for SLE rim pattern, specific for drug-induced SLE homogeneous pattern, specific for systemic sclerosis is nucleolar pattern. So with that itself, you can actually come to most of the things. So if you ask me, most common pattern in CTD is dense fine speckled pattern. Most specific pattern in SLE is the rim pattern. Most common pattern in SLE, if you see, okay, most common pattern in CTD is dense fine speckled. If you are asked most common pattern in SLE, because we see a lot of drug-induced SLE, etc., there alone, please keep this in mind that you answer it as homogeneous. So, most common pattern in connective tissue disease is dense fine speckled pattern. Most common pattern in SLE is homogeneous pattern. Specific pattern for SLE, rim pattern. Specific pattern for drug-induced SLE, homogeneous pattern. Specific pattern for systemic sclerosis, nucleolar pattern. And this question is like, I think it's a very similar question, it's been asked so many times. Now, going back to this, numbness of our fingertips, face is tightened, ANA found to be positive, what more you want? ANA positive is the window for a connective tissue disease, which means all these are possible, all these are connective tissue diseases. When they present with numbness of the fingertips, which is probably due to Raynaud, then again for Raynaud, systemic sclerosis, Sjogren, SLE, all the three can actually produce Raynaud. ANA positive, again in all the three you can get, but tightening means you are thinking more in terms of systemic sclerosis or an overlap, and nucleolar pattern means you fix the answer of systemic sclerosis. Okay, again, very simple. Once again, to keep in mind that rheumatology is a small topic from where we get a lot of questions. So, it's better to actually study CTD. You will definitely enjoy learning CTD because it's very interesting. It's very challenging as a clinical person, but very interesting to learn also. So, that's about this question. We go to the next one. 68-year-old man presents with cough and yellowish sputum, bronchial breathing. So, we are now fixing on the fact that this is a consolidation question. Consolidation question, they have asked what is to be done. So, what is to be done again? International criteria, I don't think they would expect. International standards and national standards, what we do with particular score are very, very different. So the score is being discussed by me so many times. You can actually see this in n number of places in my discussion. I've done this in pneumonia, and I've discussed some other case, I've done it there, etc., etc. So the score is curve 65 score. Everybody would know this. 865, so that puts 1 score. C is confusion. You can't see any confusion. U is urea. More than 7 millimole per liter or more than 42 milligram per deciliter. So 42 milligram per deciliter, so it's a score 2. Then R is respiratory rate more than 30. Here it is only 20. Then B is BP less than 90, 60. Here it is 110, 70. So my score is actually 2. Score 0 means you can actually manage the patient on an OP basis. Score 1 is when you have to admit the patient, definitely. And nowadays, as per Infectious Disease Society of India guidelines, if you have an elderly person, you have to definitely admit him. That means more than 65. So here again, you have to anyway admit that person. And the score is actually 2 and above, means it's always preferable to admit in the ICU. That is also taking into consideration another index called Pulmonary Severity Index. If you go by international books, etc., like Fishman, they have said that it's only if 3 and above that you need to admit in the ICU. But again, I'm telling you, Indian setting, Indian paper, Indian patient, 2 and above, we have to admit in the ICU. Elderly patient like this, I would definitely not want to take a chance and admit him in the IP. You want to definitely admit him in the ICU, provided there is infrastructure to admit in the ICU. So, admit in the ICU without any mechanical ventilation, there is no reason to do that. And give antibiotics and send the patient home is totally wrong. Admit to the ICU, mechanical invasive ventilation, white intubating, we will not allow you, first of all. Consider admission in non-ICU setting is a point you can consider, especially with urea just above 42. So not going by strict guidelines. If a patient like this comes to me in the hospital setting, what will I exactly do if you ask me? At that point, I may even consider this. But if you want to go by guidelines straight and go by Infectious Diseases Society of India guidelines, not anything else, they mention that score 2, especially with elderly being the one reason for score, you have to better admit the patient in the ICU. So I think definitely the answer they were looking for is this one. Okay, what is in guideline, what we do in practice are slightly different. In practice, you may consider this because 42, 44, okay, patient otherwise doing fine, I might consider. But going by guideline, if you want to go by ISI, this has to be in the case of a curve 65, you have to be admitting in the ICU. Now, what you do with this is what this chart is actually discussed, and I think I've told you so many times. A score which is equal to 0 is OP management, which you can do with azithromycin or you can do with doxycycline. Score 1 means you have to add ceftriaxone to it, and score 2 and above is an ICU setting, where again it is ceftriaxone with azithromycin, but again a lot of things come into consideration, including the thought process about aspiration. So where you have to think of anaerobes or a pseudomonas like kind of thing, or maybe lung abscess complications. All these things you have to keep in mind. Patient with giant cell arteritis presented with headache, jaw claudication, polymyalgia rheumatica. So that's also a straight pick. We have discussed that so many times. A patient with giant cell arteritis presented with headache, jaw claudication, polymyalgia rheumatica, mononeuritis multiplex. So jaw claudication, headache, polymyalgia rheumatica is more than enough. It's a case of GCA. What should be mononeuritis multiplex is wrong. Okay, it comes in medium vessel vasculitis. It doesn't come in GCA. What should be the first line treatment? We discussed this so many times. The whole point about treating GCA is to prevent any visual issue. Even before you do biopsy, you start the patient on steroid, and I have told you this so many times. Steroid is the first line. Giant cell arteritis suspected. Temporal artery biopsy. Temporal artery biopsy is the investigation of choice. Negative biopsy means you go for a second biopsy. Positive biopsy, GCA is proven. But even when you suspect, you start the patient on steroid. That's the whole point, because you don't waste time, because it is all about vision. So visual loss present, you start here steroid. Even if visual loss not, then also you start steroid, because you always have a feeling that patient can have a visual loss at any point in time. So giant cell arteritis, again, very, very important topic. On the whole, once again to reiterate that vasculitis is very, very important. And from the previous question, to understand that pneumonia is a very, very important thing. So whatever question has come, if you look through the zones, so far so many questions that we have studied, every question has come from a very, very high yield zone. Like this question is from vasculitis, the previous question is actually from pneumonia, the question before that it is from connective tissue disease opening part, that is ANA profiles and then CTDs. Every question has actually come from extreme high yield zones. So at least you should be acquainting yourself with the high yield zones. A woman with hysteria who was hyperventilating, this we have seen so many times, students out of stress hyperventilating, need not be hysteria, develops carpopedal spasm. So what is this basically? So this carpopedal spasm and all these things, as and when you are having hyperventilation, hyperventilation itself is equal to what? Respiratory alkalosis. Whenever you are hyperventilating, you have respiratory alkalosis. We have discussed this so many times, Trousseau sign, the Maindy acosia, carpopedal spasm, Chostek sign. And this is a statement from my own slide. Calcium and hydrogen compete with albumin, and hence a fall in pH by 0.1 will increase the free calcium by 0.1 milliequivalents per liter. Okay, this is exactly what we have discussed. So essentially what I'm trying to tell you, hypocalcemia, hyperventilation, respiratory alkalosis, as simple as that. Okay, 10-year-old child with AIDS presented with fever and productive cough. Fever, productive cough, bronchial breathing. What more you want? Right lower lobe consolidation. What is that we are looking for? We are looking for a lobar pneumonia. Exudates in air spaces, neutrophilia, fever, cough, sputum, everything we have discussed. And whenever you have a lobar pneumonia, typical pathogens, these are the list of typical pathogens. Again, I have told you this. And the most common organism is Streptococcus pneumoniae. Once again, the topic community acquired pneumonia. So from the same topic community acquired pneumonia, we have two questions. Herb 65 question was a little tricky. And mitral stenosis question is also a little tricky, where it is purely the examiner's discretion. If he says that it is MS, nobody can question. If he says it is TS, nobody can question. And he need not give the answer out in the open also. Curve 65 also there is a trick, there is a catch. Because if he goes by pure guideline, he can say ICU. If he says that, okay, urea is still normal, that means urea up to 50 is considered normal. Urea is still normal. If he says so, then you cannot question him. So that's what I'm saying. So two questions which probably there are a lot of dummy questions in the paper. Like if you look at 200 questions, I believe that they will be taking into consideration only 190. Rest 8 to 10 may be dummy, where they'll give 4 marks to everyone. It's just to confuse you in the exam hall and to just kind of make you, test out how much of composure you have. Because if you are a composed person, you will understand that this question doesn't make so much of difference. Let me move on. But most of the people, what happens is they come back after the exam and they have this flashback phenomena. Like when you go and sleep, even I had this after writing the exam, you just keep thinking about this question, what was the answer, what did I do, what did I not do, etc., etc. That happens. That's actually a good sign. It means that you're preparing. Fever persisting after 5 days of antibiotics, the first thing you have to think about is empyema. This I have told you again so many times. So here the answer is Streptococcus pneumoniae. I don't know why some people thought of pneumocystis, etc. Just seeing AIDS is not the way to think of pneumocystis. Gone are those days. 36-year-old woman presented with claudication in forearm, transient loss of vision. This, if you have attended my classes and you're not writing, means you better not talk with me again. So femoral pulses are weak, retinal hemorrhage. It's a typical case of a vasculitis, large vessel vasculitis, which is Takayasu. So you got one question on temporal arteritis, another question on Takayasu arteritis. So that's great. And both the questions are very simple and very straightforward. These are the other names: Takayasu, non-specific iodoarteritis, occlusive thromboiotopathy, pulseless disease, iotic arch syndrome. And I have told you this exactly like this, how a patient comes with pain, difficulty in raising the upper limb. It's upper limb claudication. Then you check for pulse on either side, you check for BP on either side, you look for the bruit, and then you do a CT angio and you fix up the diagnosis. So onset before 40, limb claudication, decreased pulse, unequal BP, bruit, and angiographic evidence. Okay, so temporal arteritis, Takayasu arteritis, even we have done a comparison. So that's it. This is another kind of a question. Feeble femoral pulse, BP of the upper limb 186/90. Chest X-ray showed enlarged intercostal artery. So similar kind of a question, coarctation of iota. I'm not discussing it because already Singaram has done that. So but just to keep in mind that this is also very similar. But feeble pulses, you know, with intercostal artery thickening, this cannot be anyway Takayasu. This has to be only coarctation. Patient presence with seizure on evaluation is exactly the same thing that we have studied so many times. Just to give you the next high yield area. The next high yield area is hyponatremia. So next high yield area is hyponatremia. Nothing much to actually think here, isn't it? What is the criteria for SIADH? Criteria for SIADH itself is the patient is euvolemic with a low serum osmolality, increased urine osmolality, with increased urinary sodium and absence of identifiable pituitary thyroid renal disease. So here you are having a urine osmolality that's very high, serum osmolality that is lower in comparison to urine osmolality, and definitely what you are looking for is hyponatremia. Every single thing about hyponatremia is important. We have discussed hyponatremia after posterior pituitary inside endocrine. Please go back and watch that. I think most of you have watched it already, and that actually tells you as to how to form an approach to hyponatremia. And the fun of it is that we can use it in the hospital. We can try treating patients. Whatever I have tried to teach you, the emphasis is definitely on clearing the exam. But more than that, you will experience the same set of problems when you go to the hospital. And there, when your knowledge comes in handy, that is when we really feel happy from within inside. It is not just to answer this question that we are studying. We are finally studying all these things to make some kind of a difference in somebody else's life, which is possible only with holistic learning. Okay, so this is basically, I'm not wasting my time on discussing the criteria and such. This is what it is: decreased ECF, inappropriate increased urine osmolality, clinical euvolemia, elevated urinary sodium, absence of another disease. Okay, 37-year-old woman presents with headache of 6 months duration, chronic long-standing headache, taking analgesic regularly. Okay, taking analgesic regularly. Headache recently increased in severity for 3 days but reduced on stopping analgesics. So there are 129 causes for headache actually in this textbook called Bradley. So you can't study all the causes. I have divided headache into 2 modules where tension, migraine, and of course chronic persistent headache I have discussed. Medication overuse headache is something which I have not discussed. And I told you that the most common cause for headache is definitely tension type headache. And tension type headache is possible from this headache for 6 months, yes, possible. Taking analgesic is her choice. Headache recently increased in severity for 3 days. Tension type headache is not something that increases in severity generally. It stays like that and doesn't affect activities of daily living. That's what we have discussed. This is exactly what I told you. And it's a frequent or continuous type of headache, mild bilateral band-like sensation, and it's sometimes worse at the end of the day as you work. So definitely this is not that. Then migraine, no chance. Unilateral photophobia, phonophobia, vomiting, throbbing type of headache, all that. So definitely not migraine. Chronic persistent headache, definitely not chronic persistent headache, because you can actually see that there is increase in severity for 3 days but reduce on stopping analgesic. Definitely not going hand in hand with that. So these 3 things we have studied. So if you apply a bit of logic, you can write it as medication overuse headache. Although I have not taught medication overuse headache, I know that, but by theory of elimination, I think you should be able to write this. Medication overuse headache is a headache present on more than 15 days per month. Regular overuse of one more drugs. Headache developed a worsening during medication overuse and resolves within 2 months after discontinuation of the overuse medication. This is from Lancet. This is exactly the diagnostic criteria for medication overuse headache as proposed by the Headache Society. So I think with this you understand that the answer they are looking for is medication overuse headache. But even if you don't know this entity called medication overuse headache, I think you can write the answer by eliminating the other options. And even if you show this question to my father, I think he will write the answer, because anybody who is not a doctor will read this and say headache increased for 3 days but reduced on stopping analgesic. What is the meaning? That it has got something to do with the analgesic. So he will say the answer is yes. So with that much of common sense, you can obviously write the answer. So that's also there. Okay, this I actually got from Jeffrey Burkon, one of the very premier commentators of the 90s and early 2000s. So he used to, when you say some of the batsmen getting out to full tosses or getting out to very loose balls, he used to make comments like this. Even my mother would have hit this for a boundary. So hearing this so many times, that's also possible. So tension type headache, I just want you to remember this key term: female with a depression, with a tightness or a band or a pressure, and vomiting, photophobia, phonophobia aggravated by movement, all that strike off. And acute attack, you can give NSAIDs. Chronic, you give prophylaxis with TCS. But this question doesn't fit into that box. So if you know the other causes, I think it is easy. The next one. This question, I think, created a lot of row and a lot of confusion with respect to students. And I have so many of these students after the exam messaging me about this is this is that, etc. But prima facie, let me tell you that I have no interest in those things. If you message me a case which is like a person who is your relative or your friend or somebody who is your neighbor even, and then you are having a difficulty in solving it out and difficulty as a team you have, and you call me, means I'll be so glad even at 2 a.m. in the morning to sort it out. This exam is over, it is done and dusted, and to again go back and pause and think about it really does not make sense. Let us go back to this question from what we understand now. So this question is on a person who is 50 years old, who is having hypertension, diabetes, hypercholesterolemia, which probably means that he is a candidate for ACS. Yes. Is he having chronic stable angina? Chronic stable angina. He may be having chronic stable angina, old, but right now he's coming with recurrent pain. Okay, with each episode lasting for 3 to 5 minutes and subsiding with nitrates. What will you actually do? So here the biggest consideration is that whether he has actually developed ACS. ACS guidelines, NSTEMI guidelines keep changing day by day. And in 2021, we have now got a phase where we'll be reading that and teaching that probably next time around, where there even also you have to take the patient for PCS. A lot of changes have happened. And now what they say is like STEMI guideline and NSTEMI guideline are almost the same now. So if you consider a person whose chest pain is recurrent, chest pain is continuing, chest pain is not relieved with sublingual nitrate, obviously we are looking at unstable angina. I told you that there is no entity called unstable angina now. It is either ST elevation ACS or non-ST elevation ACS. So this is a case of a non-ST elevation ACS. Non-ST elevation ACS can be 95%, 97%, 99%. It's possible that way. So this is a non-ST elevation ACS. In the treatment of non-ST elevation ACS, what is the next best step? Okay, this is the question. In the treatment of non-ST elevation ACS, if you go by the 2020 criteria, and what I have taught you in class also is, non-ST elevation ACS, they have said if the patient is having pain relief of pain is the first major step. Second step is to give antithrombotics. Antithrombotics would include antiplatelet and anticoagulant. Antiplatelet, anticoagulant. Among anticoagulant, obviously, low molecular weight heparin. This is what the guidelines say. Okay, so if you go with that guideline, adding clopidogrel much better than that is obviously enoxaparin. Increasing the dose of beta blocker, these are out. Question is whether to give GTN infusion or give enoxaparin. Both are first line things. Okay, both are first line things. Both are correct in this question. But if the patient is not coming with chest pain, he had an episode of chest pain, no chest pain, then again chest pain, then no chest pain. If you read this question, you understand that each episode lasting for 3 to 5 minutes and then recurrent pain. So if he is coming to, at that point in time, he does not have a pain, then obviously the answer is enoxaparin. If he is coming with ongoing pain, then the priority is definitely to reduce pain. But you shouldn't ask me, then are you not giving enoxaparin? That you should go and ask the examiner. We will do both together. Okay, we will do both together. We'll start GTN infusion and also we'll give enoxaparin. That's what a normal person does. But the point is, if you are asking me which is the next best step, we'll do both together is my answer. But in this question, as they have not mentioned, is the patient is coming with chest pain, probably you can think that enoxaparin is the answer. But if he is coming with ongoing chest pain means, then we give infusion and give enoxaparin. Just like you think of a patient who is coming with STEMI, you are referring to the center which is capable of PCI. While referring to the center which is capable of PCI, won't you give something to alleviate the chest pain? Will you send the patient like that? But for the exam, if you get a question, what is the treatment for STEMI, you will say PCI is the treatment. Does it mean that, well, does it mean that you don't do anything? No. See, nitrates don't work so much in STEMI, I understand that, but at least morphine, whatever will you give? You will give definitely, right? So next best step, if you ask me in a patient with ongoing pain, is definitely to alleviate the pain. Patient comes first, pain comes first. That's obviously the way to go. And I have seen patients who have thrown VTBF like that. So maybe with ongoing pain, they may throw some arrhythmia also. But if it's not mentioned like exactly having pain at this point, okay, enoxaparin. So this is the third question where I think the examiner is kind of, we really don't know what the original answer would be. The MSTS question, the curve 65 question, and this one. But that's okay. That's how medicine is. Okay, so rest angina, new onset severe angina, crescendo pattern, all these things. That's what we call non-ST elevation ACS. And right now there is no TIMI score, nothing. The guidelines have completely changed. It's about taking the patient for PCI. Definitely about taking the patient for PCI. So nitrates, beta blockers, this is what I've shown you. Aspiral, clopidogrel, hydrostatin, and low molecular weight heparin. Okay, clear. So we go to the next question. This question is probably a tester, I guess, because this is a term that we use or heard names so many times, and I think I've shown you this on my slide also. A wheeze in medicine does not necessarily mean it is asthma. A patch on an X-ray doesn't necessarily mean that ATT has to be started. Again, borrowing the words of our great teachers who've taught us this from MBBS, then we didn't understand the value of this, but right now we do understand. This is a great statement. All that wheezes is not asthma. And that's exactly what the question setter also wants you to know. That there is wheeze, does it really mean there is asthma? Let's look into this question. This question is trying to test out lung infiltrates with eosinophilia. This is again my slide where I have tried to look at a lot of causes which are producing lung infiltrates with eosinophilia. And you can actually see right at the bottom I have written hypersensitivity pneumonitis, and I myself have striked it off in that particular discussion because HSP never produces eosinophilia. So when you think of eosinophilia, you cut off hypersensitivity pneumonitis. It is a 3+4. That's very important to understand. It is a 3+4 hypersensitivity reaction. ABPA is a 1+3 hypersensitivity reaction. That's why you have eosinophils there and no eosinophils here. So this is out. Miliary TB with eosinophilia really doesn't make sense. Asthma can have eosinophilia. Tropical pulmonary eosinophilia is also possible. But in this particular question, again, this is my slide on tropical pulmonary eosinophilia. A type 1 response to microfilaria in the lungs. That's why we say parasites is very important. So many parasites I have discussed there. Strongyloids I have discussed there. I have discussed Paragonimus westermanni, all those things. And paroxysmal cough and wheeze worse at night and weight loss. Gradual, this is very important. And the same thing has come for the exam, eosinophilia. So that's great to see, because a slide when you make, I try to make a slide which is mix of right and wrong. So when you make a slide where as a teacher, like you are supposed to be teaching a 10th standard student, you make a slide. My way of making slide is slightly different because I write a lot of wrong things. But apart from that, what I'm trying to tell you is we try to incorporate certain, what we think very important stuff. And when people who actually frame the question also think along similar lines, we feel little happy for that. Microfilaria are absent from the lung, hepatosplenomegaly, lymphadenopathy, diffuse miliary lesions and mortal obesities. Now these kind of exams do take us a little back in time, because as you would expect, I was also a very competitive guy who wanted to become first in the exam. So these guys who after writing the exam, what will happen is that they want to actually see how much they've scored, how much they've scored, how much they've scored. So those times there are no review sessions, there are nothing like this. So we take all the books and see whether this is right, that is right, and discuss over that, debate over that. But it really does not make any sense. But that's why I don't criticize people who are doing it now, because I myself have done it. So that's how it is. So the answer is very, very simple. It's a tropical pulmonary eosinophilia. It's a very simple question. Nothing doubt about it. And the same slide also, this also I have shown you. Difference between asthma, ABPA. Extrinsic allergic alveolitis is the other name for HSP. And you can actually see that HSP, eosinophilia negative. Asthma also, there may be mild, but still you can consider eosinophilia negative. And ABPA is what they have given, eosinophilia positive. Okay, so HSP is another very important question. Last time around we had question on HSP. Don't get it wrong. Type 4 more than type 3. IgE absent, eosinophilia absent, diffuse infiltrates versus ABPA, what is the difference, and all these things. Farmer's lung, most important protein, very, very important. Mushroom worker's lung, malt worker's lung, tobacco worker's lung, and what is associated with what is also a very, very important question. Okay, so this question is just to test out whether you know lung infiltrates with eosinophilia, what are the causes, and that in HSP, etc., asthma, etc., you won't get significant eosinophilia. This is from Fishman itself. So Fishman says that significant eosinophilia is not part of asthma. So that again is very much part of it, and this is not the way it presents. This nocturnal cough and all these things pretty much in favor of tropical pulmonary eosinophilia. That's another question. Then comes this one. This is a question which is very simple and straightforward. I think there is nothing to actually be feeling confused about this, and I have taught this very straight. 20-year-old woman, breathlessness, chest pain, whatever it is, she is a case of MS. She is having AFib. What are you going to do? MS with AFib, I am again and again telling you, I have told this so many times in class also. CHATS2-VASC score is for non-valvular AFib. Okay, non-valvular. I again and again repeat. For people who are having prosthetic valve, or people who are having inflow issue meaning TS or MS, they are to be started on VARF only. There is no data on anything else in the world, which means that the answer is just VARF. And I told you, VARF to be administered indefinitely to patients with AFib. No role for any new oral anticoagulants. This is my slide, so nothing to discuss on that. There are no studies also on any of the other things. CHATS2-VASC score is not for valvular AFib. It is for non-valvular. This I have told you. Please, prosthetic and valvular, no score, no role for CHATS2-VASC. 45-year-old woman with history of hypertension with diaphoresis, unequal pulses, STT change, etc., etc. This question will be discussed by Rohan because he is the person who is taught aortic dissection. Aortic dissection can be here, there, anywhere. So he is the person to discuss, and patient is having hemodynamic instability. Obviously, you need transesophageal echo. I think that will be discussed. That's why I'm not actually wasting time on this. Very simple, straightforward question. And it has been already discussed under cardiothoracic section. It's a surgical topic more than a medical topic. Middle-aged man with chronic renal failure on dialysis, chronic renal failure, etc. terms that are thrown into the dustbin. It's only CKD now. On dialysis, sudden collapse to ER with labored breathing, tall tended T waves. So hyperkalemia, sudden collapse. What is that you are going to see? So it's an end-stage renal disease. A patient who is on dialysis should definitely be having severe metabolic acidosis. So 7.14, 7.14, two options are possible. PCO2 2020, HCO3, you expect to see acidosis. So you want to see what? High anion gap metabolic acidosis. That's the only thing that you want to see. High anion gap metabolic acidosis means that the pH should be somewhere in 7.225 range. HCO3 5 is pretty fine, and that is compensated or not. So HCO3 24 is normal. The fall is by 19. So 19 into 1.2 should be the compensation. 19 into 1.2 is 20.9, 22.8. So 22.8 should be the fall in PCO2. So 40 minus 22.8 should be the fall, which means that it should come to 17.2. 17.2 is the number, but 20 is what you see there. Means it is not fully compensated. That's the reason why the pH is also not back to normal. If it were fully compensated, then the pH would have been back to normal. This is something which you see very, very often. This is a very practical question also. For the exam, it's a very, very simple question. This is something which all of us should be. You should be trained in your medical college. I believe that a college that doesn't train somebody to give calcium gluconate in a case of hyperkalemia should never be given accreditation by the NAT board or whoever, or the MCA or whatever. Because in our country, CKD patients due to financial constraints get dialyzed only twice a week, whereas the international recommendations are all in favor of getting dialyzed thrice per week. So when you get dialyzed only twice per week, like say for example Monday, Thursday, After Thursday, the next dialysis happens to be on Monday. In between that, you have Friday, Saturday, Sunday, 3 days. So the most dangerous part of this is not fluid overload, because fluid overload is something which the patient by this time knows, he senses, he knows that okay, I am going to develop some kind of a fluid overload. But hyperkalemia is something that can kill him just like that. So when the patient presents with any kind of an uneasiness, hyperkalemia presentations can be very vague. Maybe patient feeling lightheadedness, dizziness, patient feeling uneasy, patient about to like feeling of an impending doom, patient having palpitation. Any of this can be hyperkalemia. The moment you sense that, because the ECG will actually tell you that, and a CKD patient means you know this, you should be in a position to administer calcium gluconate, 10% calcium gluconate over 10 minutes IV. 10 ml. Now you need not even actually take 10 minutes, over 2 or 3 minutes you can administer that and then straight away start dialysis, because before dialysis is started, it is important for us to give calcium gluconate, because whatever happens in the best of the centers, you will take some time to actually start dialysis. And nowadays antigen testing is also mandatory. So COVID antigen testing, and by the time dialysis is started, we are almost going to lose around 40-45 minutes. So in the meantime, knowing to administer calcium gluconate, how to administer is of paramount importance. Okay. So these are the ECG changes of hyperkalemia. Again, I have discussed the most important one. The first one is the tall peaked T wave, and above 9 we have this loss of P wave, what we call sine wave pattern. In the middle of that you have few other changes like prolongation of the PR interval, depression of the ST segment, flattening of the P wave, then decrease in amplitude of the P wave, so on, which we have discussed in detail. Okay, a patient who is a known case of atherosclerosis underwent a circumflex artery bypass. Stent is now placed successfully. He is taking lisinopril, verapamil, metoprolol. What should be added? This is exactly the same thing that we have actually taught in class. Initial conservative strategy or initial invasive strategy. So here it is invasive strategy. Initiate anticoagulation with enoxaparin, which is what we prefer. And pre-catheterization, add second drug, which could be clopidogrel or GPT2B3A, and I told you we always add clopidogrel. So that is what P2Y12 receptor blocker, clopidogrel. It's very, very simple. The same slide we have discussed. Non-invasive strategy means I told you we start what? We start the patient enoxaparin. But why I am not stressing on this too much is all this is changed. In 2021, we are having a completely new guideline where we consider NSTEMI as equal to STEMI. In NSTEMI also, it's all about taking the patient for PCI. Okay, it's not about anything else. You give anticoagulation, you give antithrombotic, you give nitrate, whatever, but within 2 hours, take the patient for procedure. That is the new guideline, which I'm not discussing here right now, but that's why I'm saying this is not exactly how we operate now. But if you have studied, it's a very, very simple question. There is nothing about it. Chronic alcoholic abdominal girth, shifting dullness, liver span, histopathological, intracytoplasmic eosinophilic inclusion. What is the content? Yes. Cytokeratin 8 and 18, that is intermediate filaments, alcoholic hyaline, maltodextrin hyaline. I've told you everything about this. Pathologist would have also told you everything about this. This is my slide showing you the other causes. Wilson, Indian childhood cirrhosis, NASH, cholestasis, alcohol, alpha-1 antitrypsin deficiency, PBC, HCC, everywhere you see this. And we've had a detailed discussion on this. Not a single person should miss this. Cytokeratin 8 and 18. Okay. Benzene, what does it actually put you at risk for? This is again my own slide. The most important risk factors that you are actually talking about: Down syndrome, defective DNA repair, Cosman syndrome, radiation in high doses, benzene. Okay, it's not right on my part to tell you that, okay, this I have taught, you should be watching and studying this. But benzene and AML, I think I have stressed on that. It's a very common question in the olden times. It's a question that was asked when I was writing the entrance exam. That was 2010-11 after. We have not had so many questions like this. But there's a very straightforward question. And again, you can actually see benzene. We have taught this. So that's why benzene, AML. Okay, so many risk factors for AML. I think most of the people would be knowing, like when we think of AML, what comes to your mind? First thing that comes to your mind is MDS to AML. Okay, any cause of MDS to AML. We also know that though very rare, PNH can actually produce AML. We know that all these myeloproliferative disorders which can transform to one another can in fact transform to AML. CML can have a blast crisis phase, ET can transform to AML, polycythemia rubra vera can transform to AML, primary myelofibrosis can transform to AML. Drug-induced AML, we study about this left, right and center, especially alkylating agents after a period of 5-6 years. Etoposide or top 2 inhibitors after a brief period, they can transform to AML. But as per Williams, if you see, Downs, of course, you know, M7 and all these things, defective DNA repair, Cosman syndrome. So if you look through the slide again, you can see this. All these primary myeloproliferative disorders, PNH you can see, aplastic anemia you can see, even eosinophilic fasciitis and myeloma also you can see. Okay, and AML, this is not the time to discuss AML. Lots and lots of things. Please do watch the modules. Quite a lot of stuff. Lots have changed. Nucleophosphamine 1 mutation is something that is gaining a lot of importance. It is actually the most frequently mutated gene in AML, and it's basically got good outcome. FLT3 ITD has got really bad outcomes. So FLT3 ITD is very, very important, and also now in our discussion we are incorporating something called midostaurin, RUNX1, CBPA, FLT3 TKD, all these things I have actually told you. And important translocations, what is the relevance of each of which we have discussed in detail, including our 1616, including our 821, including inversion 16, including 1517, which is now completely different. All these things we have actually looked into. So I have told you how to make a diagnosis also. So AML management is just like some of the great teachers have said, whether Joe Biden gets AML or a person who is working as a coolie here gets AML, treatment is same. It is a 7+3, 2 cycle 7+3, and then how you consolidate. Low risk group, we go for high dose cytarabine. High risk group definitely requires transplant. And in spite of all that, AML is one of the most deadliest diseases. What is good in AML? Inversion 16 is good in AML. 1616 translation is good in AML. Then mutated nucleophosphine is good in AML. And 821 translocation is good in AML. Apart from that, everything is considered to be bad. You can probably say when nothing is there, it is intermediate, and everything else is bad. For low risk group alone, after the cytarabine daunorubicin regime, we can go for the high DAC regime, which is the consolidation phase. But every case that we see here, take it from me, is intermediate or high risk. Every intermediate or high risk requires a transplant, and transplant is obviously the way to go. Haplotransplants or half-match transplants are also being done in a big way, and that of course is part of our discussion. So AML on the whole a very important topic, but I think this question is just to test out whether you have learned this particular point. Even if you know everything about AML, if you don't know this part, you are going to lose 5 marks. Okay, so this is again a question which we have discussed. Very happy for that. In iron deficiency anemia, which of the following, all the following are increased except, okay, this is basically something which every single person who has watched my class, this is the table that I have shown. More than that, I think I keep on repeating this. I have a fascination for this topic, primarily because in CKD also it's a big discussion topic. I think all of us have studied this. The iron stores are low. So because the iron stores are low, ferritin will be low, but because ferritin is acute phase reactant, we cannot bank on ferritin at all times. The iron that is bound to transferrin in the blood is called serum iron. So the iron load is low, so the amount of iron bound to transferrin is also low. TIBC is indirect method of looking into serum transferrin. So whenever your iron stores are high, less TIBC. Iron stores are low, more TIBC. Here iron deficiency anemia, so low iron stores, so more TIBC. Percentage saturation of transferrin is serum iron divided by TIBC into 100. Serum iron divided by TIBC into 100 here obviously will come down. So what is increasing? TIBC is increasing. So all the following are increased except TIBC will definitely increase. Percentage saturation of transferrin will definitely come down. And protoporphyrin, you know that hemoglobin, heme plus globin, heme iron plus protoporphyrin. When no iron, obviously protoporphyrin increases. And now soluble ferritin receptor is a very important thing. All that I have told you, how it's becoming more specific than serum ferritin. So serum iron decrease, TIBC increase, transferrin saturation decrease, serum ferritin low, serum transferrin receptor increase, hepcidin low, bone marrow iron stores low, erythroblast iron low. Okay, I think we've had enough and more discussion. We have done a specific module on approach to microcytic hypochromic anemia alone. So please go back and watch that, how to differentiate it from anemia of chronic disease, how things change. I think most importantly, look into ferritin. If ferritin is low, then there is only one diagnosis in the world, iron deficiency anemia. Ferritin is normal or increased, okay? Then look into serum iron, look into TIBC, look into percentage saturation of transferrin. If serum iron is on the lower side, then it is mostly going to be anemia of chronic disease. If serum iron is on the higher side, then think of sideroblastic anemia. Okay, fine. TIBC in anemia of chronic disease will be low. TIBC in anemia of chronic disease will be low. Iron deficiency anemia can have a high TIBC. Right, so that's why high TIBC, low TIBC, this is a very important point of difference. And percentage saturation of transferrin will be low in both cases. Okay, so serum ferritin low, iron deficiency anemia. Serum ferritin normal or high, still it could be iron deficiency, anemia of chronic disease, even sideroblastic. Look into serum iron. Serum iron high, look always sideroblastic. Serum iron low could be anemia of chronic disease, could be iron deficiency anemia. Look into TIBC. TIBC high is anemia of chronic disease, TIBC low is iron deficiency anemia. Okay, this we have discussed in detail there. You can always go back and watch that. Now, 18-year-old male presents to the OPD with gum bleeding, fever for the past 2 months, pallor. This is again a discussion that I have done in great detail, an extremely important discussion at every single point in your career to actually keep note of. This is something which is very important. That is an approach to a case of pancytopenia. Approach to a case of pancytopenia. Approach to a case of pancytopenia is obviously looking into the smear and then of course looking into the marrow. You're looking into the marrow to specifically look for blasts because you essentially know that the most dangerous diagnosis in a patient presenting with a pancytopenia has to be acute leukemia. Most of the cases of pancytopenia, acute setting that we see in our hospital is acute leukemia. If you're not seeing blasts, then obviously you're looking out for B12 deficiency, megaloblastic anemia, which is probably the only good diagnosis that you can get out of pancytopenia. So you may be looking for megaloblast. You may be also looking out for promyelocytes because under acute leukemia I didn't mention APML. APML is a different category now. So you can look out for promyelocytes with their ore rods and granules. You can look for megaloblasts. You can look for these cells. Suppose you don't see, you can also look for so many of the dysplastic cells, which even in the smear you may be able to make out. So MDS. So MDS, APML, B12 deficiency, AML, ALL, all these things. Now, if nothing is there, obviously we look into the biopsy, and biopsy showing only fat, this is more likely to be a aplastic anemia. So aplastic anemia is the next of ODDs. A pancytopenia with a hyper or normocellular marrow can be seen in PNH also, where mostly it is hypercellular, sometimes hypocellular, and sometimes normocellular also. All these are the common things which actually come to mind. You can make out a whole lot of other important things also from this, but this is what should be there in your mind. Always keep in mind that hairy cell leukemia is pancytopenia with splenomegaly, so hairy cell leukemia is possible. Primary myelofibrosis, which is a myeloproliferative disease, is possible. So these two things also I think you have to consider. Then of course a few infections, this and that, but I think this would be the complete list. So in this patient, low retic count, hypocellular, bone marrow examination just a fat, no immature cells, just aplastic anemia. Aplastic anemia can be inherited or acquired. Fanconi and your dyskeratosis congenita, your Schaumann-Diamond syndrome are all the inherited causes. Acquired causes, we have seen a huge list from infections and drugs and maybe most of the time no cause, but it's a very, very bad diagnosis. Very bad diagnosis if you don't have a donor, because the moment you don't have a donor, then you're left with no treatment option. The treatment option that you have is ATG plus cyclosporin. ATG cyclosporin works in only 50%, and in that 50% where it works, it takes another 6 months to work. Here, I think the patient to be pushing on without any treatment for 6 months may not be practical. So very bad diagnosis. PNH can also actually present like that. PNH can have a hypocellular presentation very much. PNH can present like this. So we should be looking for CD55, 59 definitely. But here the most obvious answer is this one. Myelodysplastic syndrome, you're not seeing any dysplastic cells. But in a general question like this, 18-year-old patient, no chance. But elderly people, aplastic, MDS, lot of times we do see. TB, of course, not fitting into this current picture. Okay, approach to pancytopenia, again I have discussed numerous times, okay. So this is another very simple, straightforward question. If you have watched the video even once in your sleep, should be able to answer this. Again, this is what we see. Causes, a lot of them. Again, you see aplastic anemia, benzene, but more important is this non-A, non-B, non-C hepatitis virus. PNH you can actually see, eosinophilic fasciitis, thymoma, pregnancy, other things. And inherited Fanconi, dyskeratosis, Schaumann-Diamond syndrome. Okay. Now, the second question is again very important. See, this is my own slide. Commonest presentation is bleeding. What is against the diagnosis of aplastic anemia? Hepatomegaly, splenomegaly, lymphadenopathy against the diagnosis. Mucous membrane leukoplakia, dystrophic nail due to telomerase repair gene, that is called dyskeratosis congenita. So you can actually watch that in total. Pure red cell aplasia, mediastinal mass. Nothing much to think, man. PRCA equal to thymoma. Again, what I have told you. Only few things I taught you about PRCA. One is this giant pronormoblast, then congenital diamond blackfan syndrome, then transient aplastic crisis, parvovirus, thymoma, CL. Only these many things I taught you. Just study this, it's done. Okay, very, very simple. And for me personally, if you ask me, this is important because we do see erythropoietin. Very rarely can produce pure red cell aplasia. Okay, so both these questions, hematology is one topic where I am so much concerned that you shouldn't even lose a single question. Hematology, rheumatology, gastroenterology, nephrology should be 100% because they are those kind of sciences, okay, which is like extraordinarily close to my system. That is one thing. Not just that they are very close to my system, there are sciences where I feel that nobody should ever ask a question outside what we have studied. It is not possible is what I feel, because that is the kind of rapport I share with those subjects. Cardiology, neurology, respiratory system are extraordinarily vast, that endocrine also. They are so vast that it is possible to produce a question outside it. These sciences are not that these sciences are easy. These sciences are more complicated. But the fact is that for an MD entrance level exam, there is a limit to which they can make it complicated. In that limit, we will be able to answer everything. That's what I'm saying. Cardio, neuro and endocrine, including respiratory, cardio, neuro, endocrine, respiratory are so vast that like whatever you teach, there is still another option that this may come. But these 4 chapters, liver and gastro 1 chapter, nephro, rheumat and hematology are 4 chapters where I feel you should get Centum, and every time I think you will get Centum. IT professional woman orders food online due to hectic job schedule of 12 to 14 hours. If 12 to 14 hours job schedule was a reason to order food online, means I think all of us would have done that. Which does not include fruits and vegetables. This is a simple discussion. MCV 120, what is possible? Iron deficiency anemia, hereditary spherocytosis don't have MCV 120. So is it a cobalamin or a folate? You can actually watch. I have told very clearly, cobalamin stores bacteria, cobalamin synthesis. We have stores. So for the stores to get deplete, it will definitely take a lot of time. That's why for a pancytopenia, we are doing bone marrow thinking it is cobalamin, which it will not be, because it will take a lot of time to deplete your stores. Here on the other hand, it is folic acid, because it is a malnutrition kind of a setup. You can see folate, inadequate intake plus dietary. Here it is more about inadequate absorption. So that's why this is going to be almost always folate. Folate is the upper small intestine, it is getting absorbed. Very important to keep in mind that it is due to dietary, on the whole due to dietary. But there it is mostly due to malabsorption. You can get dietary in vegans, but that is after a long time, because the stores are so much. Okay, you can actually see the time interval is 2 to 5 years. Here it is just few weeks. Okay, and this is much more common. Okay, very simple. Poor prognostic marker of multiple myeloma. There's nothing to actually look into this beta to microglobulin. We have studied all the markers to such a level that this should be a, what is it, jujube question. 17p, 414, 1416, 1420, gain 1q, LDH more than 2 times the upper limit of normal. I think I've told you this so many times. 414, 1416, 1420, 17p, and 17p has been asked for the exam so many times. 17p deletion. All this we have actually seen. And when to suspect myeloma is a core topic. Again, to re-emphasize on the zone. Plasma cell disorders including multiple myeloma, very important zone. Bone pain with lytic lesion, monoclonal protein, unexplained anemia with high ESR, recurrent infection, hypercalcemia, AK, radiculopathy, any of these things. That is from my own slide where we have looked into each of these things. Calcium, blood urine nitrogen, creatinine, uric acid, beta to microglobulin. Beta to microglobulin has a bad prognosis. Okay, this is generally, if you ask me in routine parlance, are we testing beta to microglobulin these days? I don't think no. I don't think yes. But this is a tested question for the exam. Been asked so many times. Okay, so please watch myeloma in detail, have a very strong idea of myeloma. Instead, we had another question on myeloma. The question on myeloma sometimes may be very easy like this. Sometimes it may be a tricky question. That's why under each of these headings, you should think of myeloma. Back pain, think of myeloma. Monoclonality, the term, think of myeloma. Anemia, high ESR, in practice also always think of myeloma. Hypogammaglobulinemia, think of myeloma. Hypercalcemia, renal failure, think of myeloma. AK, always think of myeloma. Radiculopathy, think of myeloma. Okay. Anytime proximal renal acidosis, think of myeloma. Every time it is possible. Okay. 54-year-old patient presents to the OP with fatigue, tiredness, cervical lymphadenopathy. Diffuse effacement of lymph node architecture means there is lymphoma. CD10 positive, BCL2 positive. What do you want to know? CD10 is positive in 2 categories of patients. One category of patients who have got pre-B ALL, because it is an immaturity marker. So in pre-B ALL, you see that CD10 is positive. It's called Cala antigen, and there in fact it is equal to good prognosis. That's why under 1 to 10 years you say ALL is doing well, because they are CD10 positive, and also they sometimes have this 1221 translocation, which is also good. But in adults, ALL has a bad prognosis because of 922, 411, 190 translocations. That is the reason. So CD10 can be present in a pre-B ALL, so it's not there in the option. Then CD10 is a germinal center marker. Okay, CD10 and CD23 are germinal center markers. So when a malignancy or a lymphoma arises from the germinal center, you can get a CD10. So that way, if you look at it, Burkitt, DLBCL and follicular are 3 germinal center malignancies. So they can have CD10. So inside this, obviously follicular is possible, Burkitt is possible. But Burkitt is all about this c-MYC. Okay, it's all about c-MYC, and from c-MYC those connections with chromosome 8, 28, 814, 822 connections. But here follicular lymphoma means that you are having BCL2. This BCL2 positivity, Burkitt has a more dramatic presentation, very aggressive presence with that mandibular mass or an upper GI mass or something like that. Here it is simple lymph node, elderly person, BCL2, CD10 together becoming positive, always follicular. And I have told you exactly how to go about. Okay, it's very important. You have to know. I have done a specific module on development of B cell. So that's where you can actually see this pre-B cell, the pro-B cell, the immature B cell, from where all you can actually see ALL. Then you have this naive B cell or the mature B cell, from where we get CLL. Then we have the mantle zone from where we get mantle zone lymphoma. Then we have the germinal center from where we get Burkitt's DLBCL as well as follicular. Then activated B cell, you can again get another type of DLBCL. Then we have this memory B cell and plasma cell. From memory B cell we can get what? We can get memory B cell lymphoma, which is mostly a maltoma kind of thing. You can get hairy cell leukemia where the cell is pushed into the blood. You can also get small lymphocytic lymphoma. And from plasma cells we can get multiple myeloma. Okay, I think I have told this so many times. Shouldn't ever get it wrong. This basic understanding is very important, otherwise we can't make a move forward. So follicular lymphoma, this is my slide. 1418, BCL2 on chromosome 18, small painless lymphadenopathy, everything we have discussed. There is no way that you can go wrong on this. Okay, so continuing with hematology, another very simple question. Massive spleen, fatigue, neutrophil, basophil, eosinophil, myeloblast, myelocyte, metamyelocyte. I think everybody knows this answer is very simple and straightforward. It's CML. There is nothing that you can actually confuse with this. Is there anything else in the world that you can confuse with? Nothing. Can this be acute leukemia? No, there is nothing like a pancytopenia. Is it a myeloproliferative disease? Yes, it is a myeloproliferative disease. The most important feature being massive spleen, fatigue. Of course, you can see cells of all the different lineages and there is leukocytosis also. So this is definitely a myeloproliferative disease. It is not PCRV, it is not myelofibrosis, it is not ET. Why not ET? Because all the three lineages are involved. Why not PCRV? Because it is not just a polycythemia. Why not myelofibrosis? Means there is no pancytopenia. So this can only be CML. You can rule out the others and say it is CML. Just like that also you can say it is CML. Once you know it is CML, how do you investigate and find out? I think this has something which we've had big discussions on, and I have told you this very clearly that we have come to an era where in CML there are three types of remission that we are trying for with the TKI. One is this hematological remission that we want to achieve as early as possible, where WBC count comes to less than 10,000, platelet count comes less than 4,50,000, no immature cells and disappearance of signs and symptoms. So this is one thing. To assess this, do we need a marrow? We don't need a marrow. So this is hematological response. Then we have something called cytogenic response, cytogenetics. So this conventional cytogenetics we used to do with the bone marrow. So the whole purpose of doing a bone marrow in CML was to assess the cytogenetics. And cytogenetic response is no cells containing the Philadelphia chromosome. So I told you 95% of patients will be Philadelphia positive, which means that not every single patient is PH positive. But if you look through, all the 100 will be having BCR-ABL transcripts. All of them will be having BCR-ABL transcripts, but only 95% will be having shortening of the long arm of chromosome 22. That is what is called Philadelphia chromosome. That is there only in 95. So more than cytogenetic response, I think we should be getting a molecular response. Molecular response is the crux, and that's why BCR-ABL mRNA detection undetectable by PCR. So this is the best investigation. And with this we have FISH also. So to do FISH and BCR-ABL PCR, you don't actually require bone marrow. You require only peripheral blood. So FISH, if you actually ask me, and you look for BCR-ABL, I think that's more than enough. And here, in fact, FISH and karyotyping was one option. FISH and PCR is what some people say, but whatever FISH and PCR or FISH and karyotyping, that is the answer. Because you get a Philadelphia, you know the FISH BCR-ABL translocation, you get it, that's fine. Immunophenotyping basically has no much value over here. I told you the way to go about with respect to a blood malignancy. We start with the morphology, the cytology, the immunophenotyping, the cytogenetics and the molecular genetics. That's how we see. If you look at a disease like CML, it is all about FISH and PCR. If you know FISH and PCR, it's done. Cytogenetic analysis, if you do, well and good, but now that's why we do the marrow for conventional cytogenetics. But nowadays, even with the blood, you can actually do that. That's how it is. Lab score and all is crap, man. Olden times somebody used to do. Now nobody is doing. Flow cytometry is not required here. So FISH and karyotyping is more than sufficient. This is how the cells actually look in FISH. Okay, this is to show you conventional cytogenetics, identifying the Philadelphia chromosome, and this is the Philadelphia chromosome shortening. Okay, and this is chromosome 9, this is chromosome 22. Okay, very simple. Child presenting with palpable blanching, purpura, abdominal pain, pain in the knee joint resulting in arthritis. So there isn't more evidence that they can actually give you. There is no more evidence they can give you. It's a very simple, straightforward thing. It is Henoch-Schwann line purpura. I told you everything about Henoch-Schwann line purpura. Once again, this is the third question from vasculitis. We had a question on temporal, we had a question on Takayasu. This is HSP. Just underlining the importance. Now, again, if you go through the zones that we have identified during the course of our discussion, you can see that blood malignancies are such an important zone, pivotal zone. Now we have come to this discussion on HSP. We have discussed temporal Takayasu before. So all of this are basically extreme high yield zones. Nothing starting to leave out on vasculitis also. And HSP is something that we have discussed in toto. It's now called Iga Vasculitis. There are 4 parts to this. One is the rash, which is the non-thrombocytopenic palpable purpura. Then we have this arthritis, which is large joint migratory non-deforming arthritis and all that we have discussed. And then of course we have GI manifestations, and after that renal also. So everything, and this is called Iga Vasculitis because of this florid Iga deposition. Okay, so this question is basically telling you about purpura, abdominal pain. So essentially the diagnosis is HSP. ITP can present only one way, that is bleeding, thrombocytopenia, and that's how we make a diagnosis. And dengue is not fitting the bill. So it's a very simple thing. Palpable purpura, age at onset less than 20, bowel angina, vessel wall granulocytes on biopsy. This is how the purpura looks like. Now, colicky pain, GI bowel ischemia, intersusception is the most dangerous complication. Renal 20 to 50%, asymptomatic microhematuria. Sometimes you may get in adults a problem, that is rapidly progressive glomerulonephritis, which is like IgA. That's why we do study that IgA nephropathy can have so many different types of presentation. Commonest presentation is this macrohematuria presentation, then asymptomatic microhematuria presentation, rarely nephrotic syndrome presentation, rarely RPGN presentation. We say IgA is a cause for type 2 RPGN. If you say that IgA is a cause for type 2 RPGN, then what do you actually make out? Is it the normal IgA that presents as type 2 RPGN? No, it is the IgA of HSP. That means HSP can have an IgA that can present as type 2 RPGN. That is the only thing that you have to remember. A middle-aged patient presents with slowly progressive motor weakness, nuchal rigidity, difficulty in swallowing, carrying out day-to-day activities. Provisional diagnosis of MS was made. So, MS is a diagnosis they are already giving you. Which of the following cells are affected in MS? So, this is a discussion that we have had so many times. Oligodendrocytes. You can see my own slides here. Myelin basic protein, myelin oligodendrocyte glycoprotein are the target antigens. Perivenular coughing by T cell infiltrate, inflammation, demyelination, gliosis. So, what did I tell you? This is a demyelinating disorder. Okay, demyelination is something that we do study at different levels. Guillain-Barré syndrome is also a demyelinating disorder. So what is multiple sclerosis? Multiple sclerosis is a proper demyelinating disorder of the CNS, which spares PNS and which spares the other organs. If you know like that, then it is actually very easy. Which means that do we study like MS manifestation of the lung, MS manifestation in the kidney? Nothing like that. It's a pure demyelinating disorder of the CNS, and that's why the target antigens are myelin basic protein and myelin oligodendrocyte glycoprotein, what we call MBP and MOGP. These are the target antigens, and these are the types and all those things. And it is a saltatory conduction, that is from one node of Ranvier to the other node of Ranvier, that is actually interrupted, and you are having this continuous conduction, which is far more inferior. Okay. That's it. 33-year-old woman complains with progressive loss of vision in the right half of both eyes. Where is the lesion in the optic pathway? Now, this is again a very simple question. I have shown this again in our slides, which is basically what we are looking for. You can see the right optic tract. You can actually see the lateral geniculate body. You can see right homonymous superior quadrantopia here. So, chiasmal lesions will always produce heteronymous hemianopia. That is what we call bitemporal hemianopia, what we see with respect to a pituitary tumor. Whenever we have the optic tract being involved, okay, whenever we have the optic tract being involved, we have the incongruous hemianopia of the opposite side. That's what is actually being asked in this question. So, you are having loss of vision of the right half of both eyes, homonymous hemianopia, left optic tract. Okay, very simple, very straightforward question. You can study from ophthalm or from medicine. Man weighing 70 kg had a sodium level of 120. Calculate the sodium deficit. Actually, there is nothing like sodium deficit. I have told you in our class that the amount maximum sodium that you can give on a given day is equal to 0.6 into body weight into the maximum correction, which is say 8 to 10 milliequivalents per liter. So 0.6 into 70 into 8 to 10 is what we can maximally correct. So 42 into 8 or 42 into 10 can be the answer. So maximum can be 420 or it can be 42 into 8. 42 into 8 comes to approximately 340. This is the maximum correction. So this is almost the deficit, you can say. There is no option which is exactly going by this. So the deficit, if you ask me, is the maximum correction that you can actually give in a day. So I would take it as 10 for more easy understanding. So in that way 420 can be the answer. So that is again not there in the option. So I think maybe 480 is what they are looking for. I'm not sure with the exact numbers, but while correcting sodium, I told you that we are actually not talking about hyponatremia as a sodium disorder. Hyponatremia is a disorder that is got to do only with water metabolism, and hypernatremia is basically a disorder where there is water deficit. So in hyponatremia, when you are talking about correction, I've told you so many ways to correct, but the important thing is to understand how much you can correct on a given day. How much you can correct on a given day is actually calculated with this. Okay, like for example, we are having a 70 kg person. He is having a sodium of 100. So 0.6 into 70 into 10 is suppose you want to correct. Okay, so 0.6 into 70 into 10, or suppose his weight is only say 50. 0.6 into 50 into 10. So you have 300 to be given on a given day, 300 milliequivalents. 100 ml bottles is what you see, 3% NS coming in. So how many 100 ml NS contains? 51.3 milliequivalents. So how many bottles? 6 bottles to reach 300. So 1 bottle every 4 hours, or 100 ml every 4 hours, or 25 ml every hour. This way also you can correct. It's a slightly olden way of correction, but this is also acceptable. Okay, so I think this is the answer, though exact values are not there. So maybe different also. A 20-year-old male presented with history of lower backache and early morning stiffness for 2 years. He also gives a history of bilateral heel pain. So back pain, enthesitis, because of heel pain you say enthesitis. Which of the following is the most likely diagnosis? Yes, there is nothing to actually think about this. We have discussed about these kind of back pains for I think so much of time, and we know what it actually stands for, how it actually fits the bill, everything we have actually seen. So no question, nothing, very simple, straightforward. Inflammatory back pain, 20 years, it has to be ankylosing spondylitis. For a clinical case, you can actually fight and say that TB is more common in my country, etc. like that. But for this, there is only one choice, because there is enthesitis, there is nothing more to think. Symptoms 3 months, less than 45 days, but what we see 20 years or so. Lower back or alternating buttock pain, back pain in the second half of the night, you get out of sleep because of pain, then the activity it improves. Morning stiffness of 30 minutes, insidious onset, improvement with exercise, no improvement with rest, and all this we have seen. So age less than 40, 45, insidious onset, improvement with exercise, no improvement with rest, and pain at night, with improvement on getting up and doing some activity. Okay, very simple, straightforward question. Now, pregnant woman at 36 weeks of gestation who has a prosthetic valve replacement for mitral stenosis is on VARF and her INR is found to be 3. What is the appropriate next step? This is a question which directly I have not discussed. Till now, almost all the questions we have seen, I have directly taught you. Pregnancy prosthetic valve scenario, I have not actually taught you because I really did not think it was so very important. Now, what is this scenario all about? How do we tackle this scenario? Now, right now, if you look at most of the patients in the good centers across the country are being put on bioprosthetic valve. So this question itself won't be important. When you think of a prosthetic valve and a girl with a prosthetic valve, mitral or aortic prosthetic valve, getting pregnant, first and foremost, let us understand that with the prosthetic valve, getting pregnant is a relative contraindication, not an absolute contraindication, it's a relative contraindication. In case you become pregnant, always realizing that the risk for prosthetic valve thrombosis and thereafter thromboembolism is always there. Okay, it is always there. And if it does happen, it has got a very bad prognosis. Prosthetic valve thrombosis has got a very bad prognosis. So it is mandatory for us to actually achieve really good anticoagulation. Mandatory for us to achieve really good anticoagulation because prosthetic valve thrombosis during pregnancy is a big problem. And when a patient with a prosthetic valve thrombosis comes to us in pregnancy with a thrombosis, it is going to be grade 3-4 symptoms or class 3-4 symptoms. The only way to alleviate that is to go for a surgical thrombectomy and a new valve replacement, which can be done only by the CTVS surgeon, for which the patient has to be on a bypass, for which the patient has to be on a pump, and obviously you're going to lose the baby. So it's going to be really bad. So we have to prevent this. Anticoagulation is mandatory. Any guideline would actually tell you, even Braunwald actually tells you, to counsel the mother regarding the fact that VARF is the best of the lot. Okay, in terms of preventing thrombosis, if you say that the efficiency of VARF is 4 times that of heparin, 3 times that of unfractionated heparin, which means that given an option, we should always be using VARF. VARF is the best. Okay, if you ask me, if the patient agrees to, we can put her on VARF throughout pregnancy, okay, and do an elective CS and take out the baby. That is possible, okay? But those are very, very recent concepts. But what do we think of when we look about this question, when we go about with this question? 6 to 12 weeks and 36 weeks later. These are the two areas of interest. Okay, outside this, you can always use VARF. You should be always using VARF. There is no question about it. 6 to 12 weeks is the organogenesis period. After 36 weeks, if the patient is on VARF, then obviously scalp hematoma, and those are your concerns. 6 to 12 weeks, what the guideline says, if the patient is on less than 5 mg warfarin per day, okay, less than 5 mg warfarin per day, then she can continue with that. Please don't start on heparin. It's not required because the efficiency of VARF is 4 times that of heparin, 3 times that of enoxaparin. So if it is less than 5 gram, then the risk of embryopathy is so minimal, so very minimal that we can continue with this provided the mother agrees to. So before 6 weeks, we have a discussion with the family, tell them that the risk of embryopathy with less than 5 mg VARF is so very minimal, but still if they feel that no, that so very minimal is also not tolerable for them, they can be given, of course, unfractionated heparin. That's a different thing. But generally, we can continue on a dose less than 5 mg. Once you reach 36 weeks, okay, once you reach 36 weeks, then of course, you don't want to continue on VARF because of this reason of scalp hematoma, this and that. So at the end of 36 weeks, you can stop, okay, and you can go for IV, and that can be either unfractionated heparin or low molecular weight heparin, of which low molecular weight heparin is supposed to be better off in terms of preventing prosthetic valve thrombosis. Ideally, low molecular weight heparin should be always accompanied by monitoring anti-10A levels, which is not done in many places. So stop VARF and start heparin, stop VARF and start LMWH. I think stop VARF and start LMWH is a better answer. No point in giving aspirin after 36 weeks, so that's not a point. In between VARF and aspirin combination, you can always give up till 36 weeks, but now stop VARF, start LMWH. But in this question also, I'm telling you, if she is ready for a CS, the whole team is ready for a CS, and we are not suspecting any kind of a problem during delivery. Okay, because in this, it's generally for the obstetrician to decide, but whatever said and done, CS is a procedure wherein you can actually, by latest guidelines, continue the patient on VARF and do. Okay, but we are not going to that level, we are not thinking that way. For this particular question, 36 weeks, stop VARF, start LMWH and continue. And then after again switch over to VARF. So 6 to 12 weeks is the time when if the dose is less than 5 mg, you need not do anything right now. If it is more than 5 mg, then again switch over to LMWH and then again switch back to VARF. At all other times, try to use VARF as much as possible because the efficacy of VARF in preventing a thrombosis or a thromboembolism is 4 times that of heparin and 3 times that of unfractionated heparin. Okay, so this is one question which I feel I have not discussed, which I still feel most people got it right because they've studied from here, there, etc. Patient on digoxin, potassium chloride, clarithromycin, atenolol, triamcinolone. It's a simple, straightforward clinical pharmacology question. Digoxin levels are raised by, the answer is clarithromycin. There are a lot of case reports. You can actually see that anything that impairs renal clearance, hypokalemia, hypomagnesemia, hypercalcemia, diuretics, quinidine, verapamil, amiodarone, erythromycin, clarithromycin. So we used to study as a code, right? Like Q, A, V, C. Quinidine, amiodarone, verapamil, clarithromycin. Can't be given. So obviously it inhibits the metabolism. Not just inhibiting the metabolism, you can also see that there is a bacteria called Eubacterium lentum, which inactivates the proportion of digoxin in the gut to inactive metabolites. And what happens is that macrolides have been shown to sterilize the gut. So when they sterilize the gut, that is probably the reason. That it kills this Eubacterium lentum, which breaks down digoxin into inactive metabolites. So you are now having news. So there are a lot of case reports, clarithromycin induced duct toxicity, etc. Okay, progressive painless loss of vision. I don't know exactly whether this is the question. I have shown you these images in our discussion of diabetic nephropathy because nephropathy retinopathy concordance is very important. In type 1 it is 100% and in type 2 it is 60-65%. That means if you are having nephropathy, you will be having retinopathy in type 1 100% of the time, and you will be having retinopathy in type 2 65-70% of the time. So when you look at this, this is how a hard X-ray is, which is a proper X-ray, and this is called soft X-ray, which is more like a cotton wool spot, which is due to stasis of axoplasmic flow in the retina. So if you look at the diagram asked for the exam, I think it looks more like a hard X-ray. So hard X-ray diabetes is what I would mark. But this is how a hard X-ray looks. I think that's similar to the one asked for the exam. And this is how a cotton wool spot or a soft X-ray looks like. It is not a true X-ray. Hard X-ray is a true X-ray. Soft X-ray is not a true X-ray. This is so striking. This is so striking because on the same day of the exam, I got a message from one of our students whose sister developed COVID. Post-COVID, she had a lot of vomiting and somebody prescribed her metoclopramide and she developed a lot of dystonia and some involuntary movements, and it was found out to be due to metoclopramide. So whenever you block D2, please always have this in mind that you block D2 for vomiting, please don't do that. We don't give drugs which cross the blood-brain barrier because CET acid is lying outside the blood-brain barrier. We can just block it with domperidone. Don't ever give metoclopramide. D2 blockers can cross the blood-brain barrier, especially metoclopramide, and they can block all kinds of pathways in the brain, which include mesolimbic, mesocortical, tuberoinfundibular, and nigrostriatal. So when you are giving a D2 blocker crosses the blood-brain barrier. So if it crosses the blood-brain barrier, if you're giving a D2 blocker like domperidone which doesn't cross the blood-brain barrier, that is okay. But when you give a D2 blocker like metoclopramide which crosses the blood-brain barrier, that can block the other pathways also. Importantly, block the nigrostriatal pathway, producing extrapyramidal symptoms, block the tuberoinfundibular pathway, thus causing galactorrhea. As I have told you so many times. Okay, and drug of choice is a centrally acting anticholinergic, that is Benzexol. We have discussed this in the context of hyperprolactinemia, and I think Ranjan sir has also told this so many times. Cocaine, again in forensic this has been discussed. I have also told you this, and of course you know cocaine is all about what we call sympathetic overactivity, so it has to be tachycardia. There is no way that you can have bradycardia. Okay, sympathetic overactivity is what we are actually talking about, so it has to be tachycardia. Hyperthermia, myocardial ischemia, again in the context of myocardial ischemia we have discussed this. Hypertension, I told you this so many times that before starting ACE inhibitor, only 3 things to be kept in mind. One is pregnancy, hereditary angioneuritic edema in the patient or family, and bilateral renal artery stenosis. Only after looking into this, go for that. Okay, so that is about this. This is again a question which I think Abbas will discuss in detail. So as far as I understand, this is less than minus 2.5. You are having fracture also. So obviously the patient should be started on bone forming agents first. So that's why teriparatide should be started first. Bisphosphonates have to be definitely given for more than a year. So that is the correct answer here. Calcium is okay, vitamin D3 is okay. Abbas will discuss this question in detail. Okay, then we come to tocilizumab. I think all of you know a lot about tocilizumab now. We have discussed this long back when we discussed diancel arteritis, Takyasu arteritis. That time COVID was not there. So even then we know, but right now with COVID it's attained or rather come to much more importance. CKD underwent nephrectomy, which of the following can be administered as a post-op analgesic? What rubbish question this is. Now you have not mentioned exactly how much GFR you have. Okay, if you want to preserve GFR, obviously you can use only paracetamol, but if it is end stage, whatever you use, it's okay. It doesn't matter much. Child presents with generalized edema found to have hypercholesterolemia, urine analysis 3 plus protein fat body. We have discussed this so many times. So 5 things should be there to satisfy the diagnosis called nephrotic syndrome. One is edema, then hypoalbuminemia, then hyperlipidemia, then lipiduria, and then of course proteinuria. So these 5 things should be there. It's a simple case of nephrotic syndrome. We have gone beyond this and said a lot of things as to how to go about with this, and similar questions can come also. So anytime any kind of question can come. Child means you will think that it is MCD, you will start on treatment. Suppose it is steroid resistant at the end of 4 weeks, then of course we will think of biopsy. Then of course after biopsy you will think about genetic forms of FSGS, this and that, and then of course you will start on CNIs, a lot of things. But at a basic level, simple question, nephrotic syndrome. And presentations of a glomerular disease also please look into. I have told you the 5 presentations of a glomerular disease: asymptomatic presentation, macrohematuria presentation, nephrotic syndrome presentation, nephritic syndrome presentation, RPGN presentation. Okay, and nephrology question too easy like this, something which I don't like. Nephrology is again a chapter where I expect you to score centum, not because I am a nephrologist, that is not the reason, but primarily because it is like a science which follows a linear narration kinetics. So 1 plus 1 is equal to 2, it is always 2, it is 2 whether it is today, tomorrow, whenever it is. So that kind of subject I think you shouldn't have a problem. 6-year-old girl, this is a rickets kind of question, but I think I have discussed this, that's why I thought of just taking it up. Hypophosphatemia is what you see straight away. 2.5 to 4.5 is normal phosphorus. Alkaline phosphatase is high. PTH is well within normal limits. So basically what we are discussing is hypophosphatemic rickets. We've discussed it under RT also, that proximal tubule only handles phosphorus, and that we see that the findings are all in the lower limb, it's not in the upper limb. So it's predominantly seen after the child walks. So this is a case of X-linked hypophosphatemic rickets. So I told you about vitamin D dependent rickets type 1, vitamin D dependent rickets type 2, vitamin D dependent rickets type 2 is called vitamin D resistant rickets, and then we have X-linked hypophosphatemic rickets. Vomiting, we discussed in the first question itself, hypochloremia, hypokalemia, alkalosis. That's it. There is no doubt on that. Patient with renal insufficiency presented with very low urine output, pedal edema, headache 160/90. So pedal edema, they don't want you to write amlodipine. Aliskiren is never approved for hypertension. In renal insufficiency, if you use this, you will develop hyperkalemia and all sort of problems. Chlorthalidone again in renal failure, no way, no chance. Prazosin is the obvious choice because it has got a hepatic excretion. This is exactly the slide I showed you. ACE or ARB plus CCB plus diuretic means metalazone, but CCB here you cannot use. Resistant hypertension adds spironolactone, one option, or other diuretic or alpha blocker. So here you can actually use alpha blocker. That is the better answer. Renal insufficiency so much you cannot use chlorthalidone. You can argue that if it is mild renal insufficiency, why can't you use? But none of us are using, we are not using. Again, it's contraindicated. CCB toxicity, chlorthalidone toxicity is the only thing that you will be able to get. And it will not reach its site also because of decreased filtration. 10-year-old child presented with recurrent pulmonary infection, again pediatric question, greasy stools. So steatorrhea pulmonary always equal to decreased sweat chloride, cystic fibrosis, straightforward question. Chronic alcoholic male, this is a slightly confusing question, presented with abdominal distension, reduced urine output, pedal edema, creatinine 1.6. What is the next line of management? So if I am assuming that this is a chronic alcoholic who has developed abdominal distension because of ascites, and that ascites is because of portal hypertension. So in a patient with portal hypertension, I am having AKI. So portal hypertension, when I am having AKI, what they want you to know is don't jump and mark the answer as HRS. So HRS is a diagnosis of exclusion. So if you see a patient like this in the hospital, HRS is a diagnosis of exclusion. Or rather, when will I say that it is HRS? After I have ruled out everything else possible. How will I rule out everything else possible? One, I will look at the volume. If there is some kind of a volume loss, I will replace the volume. Second, I will look into the albumin. If there is something with respect to albumin, then I will actually replace albumin. Then I will look into drugs, I will look into infection, I will look into everything else possible in the world. And when nothing is fitting, then I probably think that it is HRS. Which means that HRS criteria, if you see, is cirrhosis and ascites, no response to diuretic withdrawal, no response to plasma volume expansion with albumin, absence of shock, no drugs, no signs of structural kidney injury. Only after you rule out all these things can you say that the patient is having HRS and then treat for HRS, which is liver transplant. In this patient, I want to start from scratch. Any point in using heparin? No. No point in using pred. No point in using diuretic. Should never use diuretic. Ideally, I would have looked into the IVC volume, expanded the IVC volume and given the patient more albumin if albumin is low. That's what I would have done, but none of those options are there. Octreotide and albumin is the answer here because there is nothing else that is fitting the bill. But remember that in a question like this, HRS is always a diagnosis of exclusion, which means that HRS is a diagnosis that we think when the patient has got portal hypertension, when the patient has got a renal failure, but there is no structural kidney disease. Okay, that's the first thing. So there is no structural kidney disease. Ultrasound wise, etc., the kidney should be normal. URE should be perfectly normal. There should be no proteinuria, macrohematuria. That's again in favor of a structural kidney disease. So you know that it's more like a pre-renal thing now. Inside this, there should be no shock. Inside this, there should be no hypoalbuminemia. Inside this, there should be no diuretic. Inside this, there should be no drug. Inside this, there should be no infection. Once you roll out all these things, you come to HRS. So don't jump into the diagnosis of HRS. HRS is the last diagnosis that you consider. It's a combination of splagmatic vasodilatation and intense intrarenal vasoconstriction, but you come to the diagnosis only after everything else is rolled out. So this question is not a fully correct question, but out of this is what we can use. Terlipressin is our drug of choice, like that you can say 1 milligram for 14 days. Also try norepinephrine, midodrine octreotide combination. But remember, it's always a diagnosis of exclusion. Farmer, loose stools, rash, all these things. Again, a small module that I have done on nutrition. Please do watch that where we discuss the deficiencies. Rebecca madam has also done that. This is niacin. We had one more question. Again, diarrhea, memory loss, dermatitis. So this is a slide that I want to discuss. The same thing that we have looked into. Please go back and study that one module on nutritional deficiencies. Chronic hypertensive woman, preconception counseling, antihypertensive, obviously. ACE inhibitors are things that you can't do. So sterile pyuria, I told you when you think of sterile pyuria for the exam at least, don't think it is always equal to TB. Having WBCs in urine without having anything on culture is a very common proposition. You can see it with obstruction prostate, you can see it with nephrotic syndrome, we can see it with acute glomerular nephritis, we can see it in TB, we can see it even from a catheterized sample, we can get it in a whole lot of conditions. So don't be just carried away with that. But CT image, of course, here is putty kidney or cement kidney. All sort of questions we have discussed on this: thimble bladder, Godfall ureter, pipe stem ureter, cumulus cloud calcification, all these things with respect to TB. So remember, this exam is also one such exam where the clouds were like, I mean, it was not at a very high altitude, right? The questions were at a slightly lower altitude. But always remember, these flights that you travel, A320 neo aircraft of the Indigo, which generally travels about 32,000 feet, 32, 34,000, some of them 38,000, etc. And that is the altitude where we really don't have any clouds. So you really don't feel much of turbulence when you're right up there. That's why an exam that is too tough is generally not very turbulent. But once the flight descends, okay, descends to maybe say 10,000, 12,000 feet, that is when the pilot is tensed, everybody is tensed, and you have full clouds. And when clouds with activity, like cumulus clouds, etc. You don't see cumulus clouds so much in India. But clouds with activity, they are really going to make your life very turbulent. That's why when questions are easy, then of course the exam is going to be more turbulent, because most of the people get these questions right. And in a matter of 1 or 2 questions, everything else can change. 20 friends keep partying, 2 of them pastries from outside. Early morning means preformed toxin. Enterotoxin of staph is possible. Enterotoxin of Bacillus cereus is possible. What is an important point? We have discussed this under gastro. Staph or canned means custard. Vomiting is the most important symptom. If it is Bacillus cereus, if it is within 6 hours, then it is fried rice, and it is not this way. So this is a very easy question. It is staph. That is the answer. Shivika madam has discussed this in detail, but I have done a specific module inside gastroenterology diarrhea where I have discussed about food poisoning and the different causes of food poisoning. If you watch that, I think you can answer this very easily. And this is of course your bamboo spine. Okay, very easy question. Again, the same image we have discussed. Beta 2 receptors act where? The beginning of endocrine, I have shown you this table. This is very, very, very important. And I have told you that alpha 2 and beta act via cyclic AMP. Alpha 1, muscarinic acetylcholine receptors, everything act via IP3DAG. So alpha 2 beta is adenyl cyclase, cyclic AMP protein kinase pathway. ORS is related to glucose absorption. Glucose absorption in the intestine is all about SGLT1. SGLT2 is in the kidney. SGLT1 also you can actually see in the kidney, but primarily it is SGLT2 that you see in the kidney. SGLT1 is what you see in the intestine, and now we are looking out for this sotagliflozin, which is a dual inhibitor. It's found out to have a lot of wonders. We are expecting this drug, and that always remember SGLT2 inhibitors are wonder drugs now. This is SGLT2. We do have SGLT1 later on in the kidney, but right now SGLT2 drugs are wonder drugs. With that, we'll sign off. They can decrease oxygen consumption, reduce cardiovascular mortality when most of the other drugs in diabetes are neutral, weight loss, reduced epicardial fat, decreased leptin, then reducing BP, natriuresis and diuresis together, so no tachycardia, reducing hyperfiltration. I have done this in updates, under updates also. SGLT2 inhibitors are wonder drugs. So you can actually see even aspirin inhibiting thromboxylator, so many of the other questions were also there. Directly from medicine, we can actually get more than 50 questions. Okay, so the aim of this session is primarily not to proclaim that yes, you can get so many questions from medicine. That is not the reason. The aim of this session is basically to help out guys who are preparing for NEET 2022, for them to get an idea that okay, these are the core zones. Okay, core zones. I have discussed the zones in every question. So if you look at the endocrine questions, we just come back to that. When we look at the endocrine questions, what did we understand? As always, the questions will be centered around adrenal in adults. The questions are going to be centered around rickets in pediatrics, and the questions are going to be centered around thyroid in surgery. And every time we'll be having something connecting with the pituitary. So this is how the questions in endocrine are, and you have to be having good idea about these things. Nephrology, generally EBG don't get so many questions, but this time EBG mandatory must know. And presentations of glomerular disease is the other zone from where we've got a question in nephrology. Rheumatology, vasculitis, CETD, ankylosing spondylitis is from where we got the questions this time. Hematology, as always, we've got questions this time also on blood malignancies, iron deficiency anemia, and iron deficiency anemia versus the other so-called microcytic hypochromic anemias. When we look at gastro, the question this time was on HRS, which is a very hot topic once again to make you understand that anything relating to portal hypertension we can get a cause, we can get a question. Food poisoning, again we got a question this time. Nutrition, we got a question this time. Okay, under endocrine also the mechanism of hormone action, like different second messengers, from there we got beta 2 question. Okay, when we go to cardio, we got a question on MS, clinical cardiology, definitely to get a question. AFib, anticoagulation, prosthetic valve, all this is a very, very high yield zone. And pregnancy also, we got a question this time. Yes, when we go to respiratory system, eosinophilic lung disease, that is mostly to test out whether you know HSP, you know ABPA, and that part again, we got questions. Okay, neurology questions this time, were more so on myasthenia and that lower zone weakness, lower limb weakness, as well as we had this simple question on multiple sclerosis, that is your oligodendrocyte. So this is how the questions were. This is how the questions fanned out. Most of them were easy. Few of them were very tricky questions. If you ask me, doubtful questions are this curve question because they can put it either way. MS versus TS question, which can also go either way because you really don't know. GTN versus enoxaparin question, which can also go either way. These are three questions which can go either way. Either way, you can actually argue it out. Apart from that, rest of the questions had definite answers, and I feel that for somebody who has studied very solid, this shouldn't be a very tough paper. And for the guys who are watching, I'm just requesting you to enjoy this whole process of learning so that we can apply it in our clinics also, we get more confidence, and just enjoy this whole process of being able to know medicine, which is such a wonderful subject. So after having discussed NEET PG in toto, we are going to INS-CET recall. INS-CET exams happened almost 2.5 months back, and it was a collective decision that we would do the recall sessions together. So these questions are a little old. I think most of you would have actually written the exam. The results are out, so there is no stress whatsoever while watching this as to whether this is right for me or wrong for me. Again, this is meant for students appearing for the further INS-CET exams to again get a feel of the areas from where questions come. When we discuss this INS-CET recall, something that you can notice is that the areas for NEET and INS-CET are pretty much the same. Question pattern may be slightly different, but areas more or less are the same. Let us look into the first question. Now, I would like to compare this question with the question we got in NEET PG on myasthenia gravis. That was also a question on weakness. This is also a question on weakness. And this pattern to LMN I have discussed as a separate module. Please do watch that. So, bilateral lower limb weakness is what we are actually talking about. In bilateral lower limb weakness, you know that Babinski sign is positive. So, bilateral lower limb Babinski sign positive means you are talking about a UMN pathology. So, definitely there is a UMN pathology. But deep tendon reflexes are absent. Deep tendon reflexes absent means that there is LMN pathology. There is no sensory. There is no ANS. Correct? So, when there is no sensory, I know that there is no chance it is root, there is no chance that it is a nerve, there is no chance for a ganglion, nothing. So, if it is a pure anterior horn cell, you cannot have UMN. So, that's out. Muscle means there is no way that you can have UMN. Neuromuscular junction means it has to be fatigability ptosis. So all that is out. So what is possible for a bilateral LMN plus UMN plus wasting plus no sensory? This is the status. Okay, when you think of LMN and UMN combined together itself, I think without any doubt what will come to your mind? MND will come to your mind. Wasting means that anterior horn cell is also involved. So MND is basically a neurodegenerative problem, that's why ALS, where four things are actually getting involved. One is the pyramidal fibers, second is the corticobulbar fibers. Because the pyramidal fibers and corticobulbar fibers are getting involved, you can get UMN features. Then anterior horn cell in the spinal cord and the cranial nerve nuclei in the brainstem. So because cranial nerve nuclei in the brainstem are getting involved, you can get a bulbar palsy like kind of picture. If corticobulbar fibers are getting involved, it is pseudobulbar palsy. So it can be either bulbar or pseudobulbar palsy. Anterior horn cell is a reason for LMN weakness, because of which you will be having wasting, atrophy, fasciculations and all that. Pyramidal will be the reason for UMN weakness, that's why you get pressure reflexes. In simple terms, starting with a cramp or a fasciculation, and then of course when you are getting an atrophic limb, on atrophic limb when reflexes are exaggerated, there is only one diagnosis in the world, that is ALS. Tropical spastic paraparesis I have discussed is a pure UMN lesion. GBS, everything happens very fast, it is LMN and it is a monophasic illness. You can't have this long history and stuff. Multiple sclerosis is a pure CNS demyelinating thing. So this is also on localization. So that question on myasthenia was also on localization. This question is also on localization. We have quickly tried to go into what is localization, and I think that should pretty much settle the whole issue. They have told you there is no sensory, there is no autonomic per se to say that there is no myelitis. If you have a spinal cord issue also bilaterally we can have weakness, isn't it? But then again that will be LMN at the level and UMN below that level, that's possible. So here it is not that way. Then sensory, complete loss below that particular level, here again not that way. Autonomic dysfunction absent, and I have told you specifically in ALS, this is my slide, sensory, autonomic, bowel bladder, cognition, extraocular muscles, nothing will be involved. Most patients related to local weakness, cramps may be the first symptom, worsening at night, fasciculations frequent, multiple, and maybe sometimes focal, sometimes generalized. What we do say is when you are having atrophic limb with fasciculation with increased DTR. Sometimes bulbar onset with dysarthria followed by dysphagia, maybe bulbar palsy or pseudobulbar palsy. Pseudobulbar palsy is UMN, bulbar palsy is LMN, pseudobulbar palsy is what we say British Constitution, you say, and bulbar palsy, pa, la, ta, etc. Depending upon pa is from your lips, la is from your tongue, ta is from your palate, so like that, depends. Okay, so simple question. THC, which of the following initial screening tests are used to diagnose diabetes? It's a funny question actually, because diagnosis of diabetes I have discussed in great detail. ADA criteria for diabetes, you know, more than 200 random blood sugar with symptoms, or HbA1c more than or equal to 6.5, or PPBG more than or equal to 200, or fasting plasma glucose more than or equal to 126. This is our criteria. Everybody knows this criteria. I have taught this criteria so many number of times, and you all know very clearly in endocrine we have discussed that any one is actually enough. Now we go back to this question. This question is asking you in a PHC which is used to diagnose. This is used to diagnose, this is used to diagnose, this is used to diagnose, this is also useful for diagnosis. But here, because no symptoms are mentioned, this cannot be used. So 1, 2 and 4 can be used to make a diagnosis of diabetes. Correct? 1, 2 and 4 can be used. But in a PHC, do we have provision to do HbA1c? If you ask me, I have worked in a PHC during my internship. Of course, we had PHC postings. After which I have not worked in a PHC thus far. So I do understand very clearly, you also do understand that there is no provision for HbA1c. So if you think like that, 2 and 4 are the options. So 2 and 4 will be the answer. Okay. Is there a PHC having provision for HbA1c? Please do let me know. From what I understand in a PHC, that is not there. So 2 and 4 will be the answers. Okay, interesting question anyway. Newly diagnosed HIV patient present with fever, cough, hemoptysis, you know this. Sputum sample showed acid plus bacilli. Everybody knows this. This is my own slide. Patient with active TB is diagnosed with HIV. The first priority is to start TB. First priority is to always start ATT. I think all of us know this. We really know that there is always a risk for something called iris. So less than 2 weeks or 2 to 8 weeks depending on the CD4 count. There can be paradoxical worsening of symptoms, especially if you start with a low CD4 count within 12 weeks and when there is a rapid reduction. So one of the most important thing is risk factors: low baseline CD4, high viral load, shorter interval, disseminated TB, and great reduction in viral load. So anytime when you have a new exacerbation of an already present lesion, radiology worsening, CNS worsening, lymphadenopathy, fever, anemia, weight loss, always think of iris and start steroid. So prima facie, this question is just to test out whether you know. So start ATT and then ART. Okay, 2 weeks or 2 to 8 weeks. So always start ATT first. Simple question. We have discussed the same scenario. Please go back and see. So it's a straightforward thing. Okay, pathology from the given flow volume loop. Flow volume loop is a separate module that I have done. I have shown you the normal flow volume loops. Krishna Kumar has also told you in detail about this. The issue with expiration that we have with an obstructive disease, and that's how we have this type of flow volume loop in obstruction. Fixed airway obstruction, you know that this is how it happens uniformly in inspiration, expiration. With a variable extrathoracic, you are having problem during inspiration. With a variable intrathoracic like a tumor or a chondromelia or a mediastinal adenopathy, you are having a problem during expiration, and that's why this is normal. This is basically your obstructive. This is fixed. This is variable extrathoracic. This is variable intrathoracic. And this is again my slide to show you the same thing. Tracheal stenosis with a fixed obstruction. That's how it looks like. So fixed central airway obstruction. And flow volume loop, we have a separate module. Please go back and watch that. Every time they ask this question in names, and you know that in physiology you can learn this or from medicine. Confusion, thirst, abdominal pain, pallor, thoracic spine tenderness, osteolytic lesions, and this is a question which is per se centered on myeloma. There is nothing for you to basically think outside this. Hyperparathyroidism can produce hypercalcemia, but definitely pallor, thoracic spine tenderness, osteolytic lesions, definitely not the way to go forward, and PTH should be in thousands. It's definitely not what is asked. Milk alkali syndrome, again not what they have actually looked for. Simple question on myeloma. We have discussed this so many times. Hypercalcemia is the reason you are having so many symptoms. So anytime hypercalcemia, osteoclast activation is from my own slide. We have discussed this: bone pain with lytic lesion, monoclonal protein, unexplained anemia, recurrent infections, AKI, radiculopathy. Okay, so if you know the basics, this question is actually very easy. Sinusitis, ulcerative lesions of the nasopharynx, nodular lesions, cavitation of the lung, renal failure. Oh my god, most useful investigation in this patient. It's a very, very clear case of granulomatous with polyangiitis. I told you upper respiratory tract 95%, lower respiratory tract 90%, upper respiratory tract 4 manifestations possible, sinusitis is possible, midline nasal deformity is possible, serous otitis media is possible, and subglottic stenosis is possible. Lower respiratory tract, I told you, lung infiltrates is possible, cavitating lung lesions are possible. So it's very clearly GPA. Most useful investigation, if you ask me, obviously we start with ANCA. Without ANCA, no way forward. We know that it is a necrotizing vasculitis with fibrinous necrosis and granuloma formation, which is obviously the way to diagnose by showing biopsy to show granuloma. But most useful investigation, obviously, if you want to make a way forward, that has to be with ANCA. So ANCA is what we do. Then of course biopsy we will do later on. But if you ask me, most useful is a word which is very, very deceptive. No? You can't actually guess out. You ask me how useful my class is, then how do you say? You can't say it's useless. You can't say it's very useful. So useful should be in a particular context. That means how useful is this class to clear the entrance exam. Then you can look at the class, look at the number of questions and say that, okay, this is so much useful or so much useful, less useful, etc. But when you say most useful investigation in this patient, for what do you mean? Say most useful investigation for diagnosis or treatment or in what purpose? I would say still as a treating doctor, I would do ANCA here. So that is my answer. Again, to show you C ANCA, P ANCA, this is necrotizing vasculitis with fibrinous necrosis. C ANCA you see most commonly vaginal, 40% microscopic cholangitis, 5% EGPA, and renal limited vasculitis 20%. When you look at P ANCA on the other hand, it is maximally positive in renal limited vasculitis. Then microscopic cholangitis, Church-Strauss, and 25% in vaginals. This again we have discussed in great detail. Some of the students were actually in doubt as to what can happen if you write a biopsy. Nothing can happen if you write biopsy. It's again a question where you can argue out that biopsy is very useful, but let's do an ANCA and then go further. I think that would be my take on that. Okay, but still you can argue out cavitating lesions, RPGN to show you the full crescents, which is parietal epithelial cell proliferation. So once again a question on vasculitis. So there also we had 3 questions on vasculitis. We had question on henochronal purpura or Iga Vasculitis. We had a question on temporal arteritis or GCA. We had a question on Takayasu. Here we have a question on Wegener's, just showing that recurrent epistaxis, I would think of Wegener's, episcleritis, I'll think of Wegener, pseudotumor, arthralgia, peripheral neuropathy, everywhere. Yes, envelope shaped calcium oxalate crystals. More a urology question. I showed you all these things. This is the different polymorphic shapes, that is rhomboid most common uric acid crystal, envelope shaped calcium oxalate dihydrate crystal, dumbbell shaped calcium oxalate monohydrate crystal, then star shaped calcium phosphate crystal, hexagonal cysteine crystal, coffin lid, that is your struvite stones, magnesium ammonium phosphate stones. Then comes your cholesterol crystal, this is your broom brush shaped crystals. All these things we have discussed, enough and more. Discharge of a COVID patient, what will you inform him about? Repeating RT-PCR is rubbish. We never repeat anything now. Now antigen repeating itself we have stopped. Monitor glucose levels, definitely I will do, because if given steroid you have to. Nasal pain and sinusitis like symptoms are part of the post-COVID part. Is a part of the post-COVID thing. So you can. Headache and nasal discharge, again post-COVID you get it. But anosmia is part of COVID. So post to COVID to check out for that, really does it make sense? No, I don't think so. 3, 4, 5 is what I will go for, if the options are right. Suddenly developed stroke and aphasia, looks like a big stroke. Aphasia means the stem of the MCA would have been involved. BP is normal. What is the next best step? We have discussed this in great detail as to how to look out for stroke and time is brain and the different images. Now protocols keep changing. If you look at this question on the whole, what will I do? Obviously I'll do NCCT to rule out bleed. But now with NCCT I can do CT angio. With CT angio I can actually plan for a thrombectomy, and then of course I can go forward. That is one way of looking at it. Or after NCCT I can go for an MR. I can go for MR diffusion with MR angio and gradient related images to actually go for. That's also a way to go for it. So thrombolysis definitely not. I want an image. Labetalol definitely not. Permissive hypertension is what we are looking for. So definitely don't want to reduce the BP now. MRI per se won't be enough. MRI with MR angio means okay, would have tried. Out of this, obviously CT angio. CT with CT angio. Nowadays we don't waste time. NCCT with CT angio. Unless and until there is big renal failure, we can go for NCCT with renal angio. NCCT with CT angio. If in the options you are having MR with diffusion weighted MRI with MR angio, that way also is okay. That's also a right statement. You can't say that is wrong. Either way you can go for, depending on which is available in your center and which is the best way to go forward. CT angio, call the intervention neurologist, plan for a clot retrieval, and you can salvage lot of brain. Okay, this we have again discussed in detail in NEET PG we didn't get a question on stroke. Here we did get a question on stroke, and stroke is obviously very, very important. Atrial fibrillation, choose the correct statement. Novel oral anticoagulants are used in the treatment of MS. I told you MS, only VARF, only VARF, only VARF. Anticoagulation should be given in patients with ischemic stroke due to atrial fibrillation. That actually is a little bit of a controversy. Ischemic stroke, what we are now being taught is that 1 hour within the first day in TIA, third day in mild, sixth day in moderate, and severe means 12th day. You can give anticoagulation. So anticoagulation should be given, that's right. NOACs are contraindicated in prosthetic valve. I told you prosthetic valve or inflow lesions, no way NOACs. So 2, 3 correct. Then all patients with atrial fibrillation who are not candidates for cardiac surgery can be started on beta blockers. There is nothing like that. In fact, people were using beta blockers prior to surgery in the past. Now nothing like that. 2 and 3 are the correct option. This is not exactly taught, but this statement was taught in class. This statement is taught in class. This statement, prosthetic valve per se, I did not teach. So you can say that I have not taught this, but I did mention that NOACs have no role here. And all patients with atrial fibrillation are not candidates for cardiac surgery, can be started on beta blockers. It's rubbish statement. So 2 and 3, that's it. Not a major diagnostic criteria of neuromyelitis optica. So there MS, here neuromyelitis optica. We have discussed neuromyelitis optica properly. This is my slide where I have shown you very clearly that optic neuritis, transverse myelitis, no correlation between that. 3 segments have been involved, anti-aquaporin 4 antibody, normal MRI. With this, if you come and answer this, myelitis is obviously there, optic neuritis is obviously there. Anti-aquaporin 4 antibodies have to be seen at the area postrema. So unexplained hiccup or nausea or vomiting explains that. But focal epilepsy, it's definitely not possible because focal epilepsy should have an abnormal MRI. So even if you don't know area postrema syndrome, you can say that focal epilepsy is not possible. This is neuritis, myelitis, nothing to do with the brain per se. So that way you can answer that. But this is the current criteria, which also includes anti-aquaporin 4 antibody with optic neuritis, myelitis, area postrema syndrome. Then brainstem syndrome, narcolepsy or symptomatic cerebral syndrome. Okay, so that much of knowledge is not required at your level. Even if you know optic neuritis, transverse myelitis, 3 segments getting involved, no correlation between that with anti-aquaporin 4 antibodies, with sometimes the area postrema syndrome, that is with vomiting, with the brainstem syndrome, sometimes that's more than enough. Okay, and most importantly to know that MRI brain is normal because that can help you come to the answer over here. Okay, so very simple and very straightforward question. Some people thought it is tough, but I think if you know your concepts properly, if you know that myelitis, neuritis are right, then you can think out that epilepsy has to be wrong because focal epilepsy is always due to a particular cause. So you cannot get focal epilepsy without having a particular cause. That way, that is always going to be wrong. Here MRI is normal. Acid-base imbalance is a tough question. Suspected in a patient, which of the following would you use to determine? We know that arterial pH, of course, has to be the right answer. Venous pH, PO2, PCO2. We do use only arterial. We have no data on venous. Very recent studies have actually shown this. You can see peripheral venous blood gas analysis. And that PCO2 is basically comparable. You can see it's comparable. But when we look into PO2, PO2 is not at all comparable. Which means that venous PO2 has no value. Everything else venous has got a value. So that means that arterial pH, venous PCO2, all these things are actually correct. But venous PO2 per se has no value, nothing. So would you use to determine acid-base imbalance means I will use arterial pH. Because I am using arterial pH, I don't need venous pH. I will use venous PCO2 because it has got value. But venous PO2 has basically got no value. So 1 and 4 are the correct statements here. I don't have an option like that. 3 I wouldn't use because 3 has no much of value. So probably the only thing I want you to remember from here is, if the options are wrong, that venous blood, the something that has got absolutely no value is PO2. PO2 between arterial and venous blood are strikingly different. Other things can be compared. It's a tough question because no many people actually know this. Peripheral venous blood gas analysis, an alternative to arterial blood gas analysis, is what they have tried this as. And I found out that almost all the time it is correct except for venous PO2, which does not make much of a sense. Again, a question on ABG. Tough question, but which of the following does not show both hyperkinetic and hypokinetic movements? We have made a classification and seen very clearly what stands for hyper and hypo. So I have said that chorea is pure hyperkinetic and Huntington's chorea has to be hyperkinetic except for the Westphal variant, which we are not looking at. So chorea, athetosis, tics, they are all pure hyperkinetic movements. Tremor is a hyperkinetic movement because you get it with akinesia and rigidity. Parkinson is a combination. We know Parkinson is a combination. Wilson is like associated with Parkinson. It's got Parkinson-like features. Neurodegeneration with brain iron accumulation is a syndrome which not even DM neurology PGs are confident about. What they are saying is even they have not diagnosed a case inside 3 years. So it has combination. Just feel it like way. If you know a very simple concept that chorea is hyperkinetic, you can answer this. You don't need so much of a brain to answer this. You don't have to look into the other option. If you know chorea is hyperkinetic, except for the Westphal variant, you can say that, and that is a juvenile thing. You can say that this is a question where chorea is hyperkinetic, rest are combination. And Parkinson, you know, is always a combination where akinesia, rigidity are hypo and tremor is hyper. Okay, this is what we have studied, and so many things which we try to include under this, like Wilson, which are pretty much like that. Which of the following is the cell of origin of CLL bar SL? So this is a wrong question, completely wrong question, because CLL has got a cell of origin which is very different from SLL. CLL arises from the naive cell, or what we call mature B cell in the blood. Okay, SLL arises from the post-germinal center part, that is from the memory B cells. So I don't know. Okay, so here memory B cell is not there in the option, so I can write naive or mature. But if both naive and mature are there, they are one and the same. I don't know what they are expecting. So please go back and see this. In NEET also we had a question on this. This question may be interpreted wrongly. That's what I feel. For practical purposes, remember that we start with the pro B cell stage where we have CD34, we have CD19, and of course we have surface immunoglobulin, which is not complete because the rearrangement part is not done. Then pre-B cell, this is from where most of the lymphoblastic leukemia develop, where we have CD10 emerging. And then of course we have the immature B cell, all this is in the marrow. Then comes the mature B cell or the naive B cell, which is in the blood. That is where you see this full molecule with the surface IgM and surface IgD, but by the time CD10 is not there. Then from there it goes to the mantle zone. Mantle zone you have CD5 and cyclin D1. Then it goes to the germinal center. Germinal center, I have told you about the markers like CD10, CD23, etc. And from there we have the memory B cells and we have the plasma cells. This is how it works. Here ALL, here CLL, here mantle zone lymphoma, here diffuse large B cell lymphoma, Burkitt, and your follicular lymphoma. Burkitt can also come from the activated germinal center. Then your plasma cell dyscrasia, that's myeloma and stuff. So memory cell includes marginal zone lymphoma, and of course hairy cell leukemia and small lymphocytic lymphoma. Okay, but again very sad, after having studied all this to see a question like this, I think the question was something else that we would have forgotten or we may not have remembered or recollected it properly. Which of the following are used in the treatment of sideroblastic anemia? I think there is no reason for you to even think about this once. Just like that market as B6, I have told you this so many times. What is sideroblastic anemia? Hemoglobin is heme plus globin. So heme is iron plus protoporphyrin. So if there is enough iron but no protoporphyrin, so no protoporphyrin means that it is coming from ALA. So ALA synthase requires pyridoxal phosphate as a cofactor. So very simple terms, it is B6. Okay, and we have discussed some very important catch points with respect to sideroblastic anemia, how you differentiate. I told you in the discussion on NEET PG as well that we look into ferritin first. Then if ferritin is low, it's iron deficiency. Ferritin is high, then we look into serum iron. If that is low, then it is anemia of chronic disease. Ferritin and serum iron both high, we think of sideroblastic anemia. It has a dimorphic blood picture. Ringed sideroblasts will be seen in the marrow. Pappenheimer bodies are seen. All these things we have discussed. Okay, and few causes also we have seen. Inherited cause ALA synthase deficiency, acquired cause myelodysplastic syndrome, all that we have seen. It's a very simple question, biochemistry medicine integration question. This is all about HCM. Most likely cause of death in HCM, we have discussed 10,000 times, is sudden cardiac death due to arrhythmia. Okay, I have told you about so many complications that can happen in HCM. One very important complication is arrhythmia. Most common arrhythmia is AFib, but most common arrhythmia causing death is of course VTAC going VFib. Okay, simple question. G6PD deficiency, I think this question has been discussed by Rebecca Madam. I have told you again, glucose 6-phosphate to 6-phosphogluconolactone, that is your HMP shunt is for NADPH. So naturally you will be having decreased NADPH, decreased reduced glutathione. Yes, 1 and 2. And lipid peroxidation, you can actually see there is accumulation of H2O2 which will lead to increased lipid peroxidation, membrane lipid peroxidation. Yes, this again we have discussed in detail, but again Rebecca Madam has done this question, so I am not going into that. You can watch G6PD deficiency where you can see all these things. Not likely to be seen in PNH. PNH can have aplastic anemia, we have discussed that already, right? PNH can transform into leukemia. PNH is all about thrombosis, PNH is all about hemolysis. Actually all these four things can happen in PNH, but leukemia risk in PNH is so very less. That's the reason why less than 0.05, etc. So you probably out of this can mark the answer as leukemia. But PNH presenting as a bone marrow failure with a hypocellular or normocellular or hypercellular marrow, very much part of it. PNH presenting as a thrombosis is very, very common, especially Budd-Chiari syndrome. PNH naturally presents as hemolysis with early morning hematuria. So all those presentations we have actually seen. It is due to defect in CD55 and 59 coded by the Piga gene. So very important to understand that it is not an inherited condition, it is an acquired condition. It is a stem cell defect. That's why all the three lineages can be involved. It just basically got to do with GPI anchor proteins, okay, which are complement regulatory proteins which are attached onto the surface of the RBC, and that includes CD55 decay accelerating factor, CD59 that is membrane inhibitor of reactive lysis. Typically characterized by one way of looking at it is acquired intravascular hemolysis, so that's why hemoglobinuria hematuria. Second is to look for thrombosis. Third is to look for pancytopenia. These are three ways you can actually look into. And it's going to be a Coombs negative hemolysis because it is not immune hemolysis, it is a non-immune hemolysis. So just look at this: episodic hemoglobinuria, non-spherocytic Coombs negative, aplastic anemia, refractory pancytopenia, thrombosis, especially Budd-Chiari syndrome. Okay, there is a chance for going to AML, but it is very, very less. If you look at this disease called PNH on the whole, PNH can actually transform into aplastic anemia, and aplastic anemia, PNH can be a cause. So if you look at all the causes for aplastic anemia, 10% of the time it may be due to PNH, and 25% of the time PNH can transform into aplastic also. Okay, flow cytometry, you look for PNH3 RBC, and of course monoclonal antibody against C5, what we call eculizumab. 34-year-old hypertensive man diagnosis stage 4 CKD, low GFR. Again, it's very similar, right? Areas, that's what. So you can use only metalazone. Metalazone is the only one that is approved. Ischemic stroke started on clopidogrel. Another attack of stroke likely to be responsible for clopidogrel failure. I have told you so many times in ACS. We are going and using ticagrelor because of the CYP to C19 polymorphisms. CYP to C19 polymorphisms is the reason why clopidogrel has gone out of favor. So many examples I have told you, reiterated on this so many times. Organism drug which is intrinsically resistant. Again, I have told you this so many times that fluconazole works only against Candida albicans. Fluconazole only Candida albicans. Other Candida, of course, you can use caspofungin, micafungin, amphotericin B, all these things. But fluconazole only against Candida albicans. Voriconazole, aspergillus, except for mucormycosis, everywhere you can use voriconazole. Aspergillus fumigatus, yes, micafungin, caspofungin can be used in Candida and aspergillus, and Candida albicans is amphotericin B. Lastly, couple of questions. Gold standard investigation for the diagnosis of myocarditis is always endomyocardial biopsy, but nobody is doing this. Endomyocardial biopsy is the gold standard. If you are looking for how we are diagnosing on a practical day-to-day basis, the answer is MR imaging, but I don't know what the original question was. Practically we use MR imaging, but if you are asking me gold standard, there's no doubt it is endomyocardial biopsy. We have discussed that. What is insulin inhibit? Insulin always inhibits hormone sensitive lipase. That's one very important thing, because if we don't have insulin, there is so much of hormone sensitive lipase, there is so much of lipolysis. Because of lipolysis, there is a lot of free fatty acid. Because of free fatty acid, which is straight going into the liver, you are having gluconeogenesis. All this you discussed under diabetes. You also have fatty acyl CoA, because there is no carnitine to take it into the mitochondria and undergo beta oxidation. So we have so much of insulin resistance. So these are the questions. So I have discussed almost everything inside this. Watch this after you watch the NEET PG record. So we have discussed the medicine questions and in and around medicine questions, just to get an idea of the core zones. And if you look at the core zones for INA-CET, you basically can't define core zones in INA-CET because they ask a lot of practical questions in middle, etc. It may be connecting 2 or 3 different things. But the whole take-home message is that if you watch each chapter, get an idea of each chapter, then go and look into the revision sessions which are integrating different topics, which are different symptom presentations, and then you do, of course, your Q bank, which is mandatory. I think most of the time you should be through. Rather than just digging deep into what I should study, this I should study, that I should study, just make the plan very simple and straightforward. Decide on your study material, fully follow that with perfection, and try and figure out about the disease rather than just thinking about the questions and what has come and what has not come. Let us just look it at a very basic level. So whether you know a topic proper. If you know a topic proper, you will definitely come all guns blazing at the end. It's about your understanding, degree and depth of understanding. Okay, and I think every time my focus is prima facie on trying to make you much more equipped with respect to seeing the patient and also the MCQ. Both are important. MCQ is of course most important, but seeing the patient is also very important. So you should be equipped. As you learn, your confidence should grow. As your confidence should grow, you should be more eager and more hungry to actually see a patient. And when you see a patient, these things should work in your system. And with that, you should be able to come to diagnosis or should be able to treat better. And that patient can be anybody in your home. It can be your relative, can be your friend, neighbor, anyone. So with that, you will be able to you will be actually able to get more confidence. And that is essentially the whole purpose of this discussion. So we have scanned through most of the stuff. If you have any doubts, you can always get back to me. But remember, questions are based on memory, so need not be correct. Answers also, I tell you, at many different places are slightly debatable. So it again depends on what that person has thought. Sometimes I feel they are dummy questions just to maybe like put you off and just to see how composed you are to go ahead with your exam. Because if you see a question on CLL like this, like you say naive cell memory, you studied so much and you're seeing naive cell and mature cell in the options, you feel like, what do you say, throwing your pen down. But that shouldn't be the case. Just hold on, just carry on with your exam. That is the only thing. Okay, so thank you very much.